I was talking to the people here. Yesterday, I got a chance to actually kind of do a little R&R, relax. So I went fishing yesterday, and I saw the sunrise here, and this was very, very pretty here in the morning. So that's me yesterday catching a fish with my uncle, and I was actually able to have a little sashimi on the boat, which is very nice, you know, with what we caught. So it was a very nice, relaxing day yesterday. So me, a little bit about me. I graduated from IU Dental School in 2005, and I just been doing a lot of CE courses to train myself to get to a level where I'm at right now. And I currently have 3 practices. I live in Indiana, so if you guys don't know where that's at, it's near Chicago, and it's about 3 hours away south from Chicago. And I have 3 practices up there, and I have a couple of associates that help me run those practices. I teach courses for IADI, which is the International Academy of Dental Implantology. I also teach courses with Hyacin, which is another implant company, and I'm also here at One Day Implants. And as I said, you know, like, education is endless. I think I learn from the people that I teach with, and it's just our field is just constantly evolving and changing. And so because of that, I think education is continuous. And I mentioned this earlier, that you have to keep up with what's changing. And technology is getting better and better, and it's evolving. Like, we have CT scans and stuff like this, and so things are constantly changing. So what's in it for 2022? You know, what's dentistry like in 2023, right? So, I mean, we had, you know, technology has changed, right? We went from the old flip phone styles to our iPhones now, and iPhone has, now it's up to 13, whatever. It's like 1, 2, 3. So many generations of iPhones, right? It's constantly evolving. So, I mean, we need to evolve. I mean, we have to change, right? We can't stay with our old technology. So, I mean, there's still a lot of offices that still take film-based x-rays, you know, film-based PAs, film-based panels. But we need to get, everything's changing from film to digital, right? And there's another step. I mean, we're also evolving to the latest and greatest, which is CBCT scans, right? And so somebody from RayScan, right, is going to talk about CBCTs?
Right.
Yeah. They wanted to do. You guys wanted to do a quick, right? So CBCT, yeah, it's important. It's very important because we cannot see a lot of the structures, a lot of the vital structures like nerves, sinus, undercuts, whatever in the bone without this valuable information. And so these days, I don't like to do implants without this information, basically. I think it's vital for success. Like, back in the days when I came out of dental school, we didn't have this. And so it was like the flip phone style. We would have to bone map. We would numb the patient, and you kind of feel for where the bone is, basically. And so you're guesstimating where the nerve is sometimes because you can't see it all the time, you know. But nowadays, we see everything. You can even see the bone density with the CBCT. So today, I mean, we're talking about implants, right? Modern day implants. What are implants, basically? So we'll talk more about CBCTs and stuff like that and why it's important. But what is an implant? It's just mostly, I mean, it can be made out of lots of different things, but it's just an artificial root. That's all it is. It's nothing special. I mean, all we're doing is people lose teeth, right? And so if you need to replace the teeth, you have to build up from the root up, right? So you have to build the root back up, and so that's what an implant is. It can be, there's lots of different types, but most of the ones that are made these days are either titanium or zirconia. I mean, they're coming up with more and more zirconia implants as well, too, because you have the holistic doctors that don't want, like, I don't know if you heard a lot about these holistic offices, but there are a lot of patients that don't want metal in their mouth, and so they want only like zirconia or metal-free stuff. And but in reality, you have to remember that zirconia actually gives off some radiation. If you take a Geiger counter and put it to a zirconia, there's some radiation levels that are given off of these zirconia crowns, zirconia prostheses or whatever. But people don't realize that, I guess. So I don't know. If I had a choice, I would say I'd rather have a titanium alloy in my mouth versus zirconia, but. But most of them are sandblasted or acid etched. Basically, the surfaces are roughened up to help the bone integrate. We call it. It's called osseointegration, and they're tapered. Usually, they're root form shaped. They're tapered, and they have what's called a Morse connection. It's a connection on top of the implant to where your abutment fits. It creates a very tight seal so that you don't get bacteria infiltration into the implant, basically. A lot of them are self-tapping, meaning that the threads are kind of a little bit aggressive to help you kind of, as you're driving the fixture in, it'll tap into the bone. And And it gives you a lot of variety of restorative options. You know, you can, with an implant, you can do like locator dentures, you can do regular crowns, you can do bridges, you can do all on X cases, multi-angled abutments. So it's just a lot of options. And it all started with this guy, Brandon Mark. He founded he coined the term osseointegration, or that's how what it was. It's just an ankylose, basically. It's an ankylose titanium, whatever, or zirconia piece in the bone. It's just fusion of the bone and the metal that we're placing. And it's revolutionized the world of even orthopedic surgeons, you know, whatever, oral surgery, everything. Just all kinds of surgery in your mouth that deals with bone plates, bone screws, metal plates, whatever, artificial knees, hip joints, whatever. It's all because of osseointegration. It's just not just in the dental world. It's everywhere, basically. But for us, it's single tooth implants. Basically, one of the best advantages of it, because of this, is we can restore teeth. Basically, we can put back teeth that patients have lost. And when you lose teeth, the interproximal contacts become open, and when people brush, they skip those areas, and so those areas get cavities. Basically, if you've done enough dentistry for a long enough period of time, you see patients in and out that get cavities in mesial or distal of the teeth that they're missing because they miss those areas when they brush. They don't realize that they have to brush that area because it's something that they don't really even think about, right? So, and also, you have less problems basically of the surrounding teeth. That's the reason why you have less problems with the surrounding teeth when you have an implant. And it increases oral hygiene basically. And implants, also, when you miss teeth, patients from a psychological standpoint, imagine if you lost 2 of your front teeth or whatever, you're walking around. I mean, I saw a show, I guess, like in Canada, I heard that like these hockey players, it's cool for them to walk around like because they lose teeth. You get into fights with them, and so they get into fights, and so they lose their teeth, and so it's like for them, it's manly for them to just kind of walk around without teeth in the front because it's a sign saying that they're a good player. They've been in it for a long time, basically. But majority of the people, you have as us dentists, we go around. If a patient ends up losing their front teeth, it's like, what am I gonna do about this? Am I gonna leave your office without this tooth here or whatever? So we have to find a restorative option that's like immediately there for them if they end up losing a tooth, right? So that's the benefit of implants. You can do like an immediate implant placement, and then you can temporize, just get them out of occlusion basically, so they can go home with the tooth. There's a lot of benefits, and so. Like your partial dentures or complete dentures or whatever, a lot of the patients don't realize this, but you get bone resorption. If you lose it, if you don't use it, you lose it basically, and if you don't have it, you lose it as well too. So if you lose teeth, you lose bone, you lose. I get patients that are like 20-year-olds that come to me, say, "Can you take out all my teeth? I want dentures." I'm like, do you realize what happens to you if you might get immediate pretty teeth, but you're bite force, So this is my denture patients. I say, you have your natural teeth. If let's just say it's 100% that you can bite with your natural teeth, you get dentures that goes down to like 10%, 5-10%. Like that's the bite force that you're going to be living with. Are you sure you really want that? And these things are just going to flop around everywhere. And with time, they're going to flop around even more because you're going to lose more bone, more gums. They're not going to seal, and so people don't realize the consequences of not having teeth, basically, and they think that just it's all about looks. It's all about looks. So, and so you can't eat right when you have dentures or partials. When you don't eat right, your health declines, and so perfect example. Like my grandfather, he just turned 99, just like a couple of days ago. They celebrated his birthday. They live up in Sacramento, so. But anyways, I think it was like when he was like 91 or 90 years old. I don't see him because I've been, like I said, I've been living in Indiana for a long time. I grew up in California, but I only come down here like to teach courses or whatever, but I don't live here. So unfortunately, I don't get to see him, but I think it was like when he was like 90, almost 9 years ago or whatever, yeah. I had him come down to the course down here because I had my parents bring him down to the course down here so I can put some implants in him so that at least I can give him some implant support dentures. So. And I wanted him to go with them supported right away. So I put like a bunch of mini implants in him. And he went home and he ate. So like the week later, right? The week later, the family was with him and he was eating, I don't know, like gakdugi, Korean daikon radish moo, right? He never ate that before because he couldn't chew it, right? And then so he started chewing on gakdugi and he was eating it. And so my family members were like, holy cow, like modern dentistry is like amazing, right? I mean, I can't believe he can, and he's healthy. He's still very healthy. He's still eating well. He's still doing well. And like, he can't hear. He doesn't wear his hearing aids, so hearing aids. So I have to yell at him to whatever, but he's healthy. He's still doing well. And this is the positive cycle that happens. But when you don't have teeth, you don't eat well, your health declines, and it's just a this quick downhill slope, basically. So it's not good. It's not good. And you keep wearing dentures, you keep losing bone, you keep losing gum, you keep losing everything, basically. Everything just keeps going downhill, basically. And like, even if you do a bridge or whatever, like partial dentures, whatever, the abutment teeth where the partial clasps onto it, it puts more pressure on those teeth, and so those teeth don't survive as long. So even the natural remaining teeth that you have, if you use a prosthesis like a partial denture or whatever it is, bridge, I mean, you have to cut the natural tooth to create this bridge, right? And those abutment bridges or whatever, the teeth that are acting as a bridge, they don't survive as long because you can get decay underneath a bridge, you can get whatever, and you're cutting down natural teeth to make this bridge or whatever, and so you're setting yourself up for something to fail down the road, basically. So, I mean, and this is just the natural consequences of what happened. You lose bone. Ultimately, you lose bone, but losing teeth, you lose bone. This is the classic witch effect. Patients look like a witch when they get old. I mean, unfortunately, it's a sad fact, but, when you lose teeth, you don't get lip support. Everything just kind of collapses. Everything just collapses. And psychologically, if you look like this, as a patient, whatever, if you look like this, this versus that, it's like these females these days, the Botox, fillers, whatever, it's all about trying to find the fountain of youth, right? I mean, it's all about looking young, looking pretty for a long time. And if you want to keep that, basically, you have to have teeth. Teeth actually supports a lot of the stuff, and it brings up your self-esteem because of it. If you don't have it, you lose it, and you lose your self-confidence, you lose everything. People, and I guess these days, because of COVID, we're wearing a mask, so that's kind of good. But, I mean, hopefully we're going to get over this, and we're going to get over this mask, whatever, world, or, mask-mandated world, whatever, and kind of, and just a toleration of, the prosthesis as well, too, like having to, when you first deliver your first denture or whatever, patients like, oh, they're gagging, and they're like, I can't wear this thing, this is too bulky, this is too big, it's like, I can't swallow anymore, it makes me drool, I can't talk. Yes, people get used to it. There's people that's been wearing dentures for a long time. They eat corn on the cob. Yes, it's true. But how many people are, like, out of the percentage of 100, how many people actually can do that? It's a select few, right? So, I mean, implants, this is where it's very beneficial for patients, for all of us, I mean, like, if it was me and money wasn't an object, I guess, of course, but if it was me and money wasn't an object, I would definitely say go with implants. I wouldn't want something that's removable in my mouth, right? And so there's lots of different options, like you have single implants, you have multiple implant bridges or whatever, and then you have these all on X cases or whatever, all on 4, 5, 6, 7, 8, 12, whatever implants you want to put in there, basically. So there's a lot of different options, So, I mean, as I said, conventional bridge, you have to cut down natural teeth. I mean, why? I mean, I always, and it should be the standard. This is like the new standard of care. You should, if a patient ends up losing a tooth, you should present them with an option of an implant, not a bridge or not like a partial or not a Nesbitt partial, whatever it is. You should always give them the option. I mean, it's their autonomy to choose what they want and what they can have. But as a doctor, we cannot just say, oh, you can get a bridge there, just because I can't do the implant, or whatever, or you can get a partial there. That's wrong. That's not something that we should be offering to the patients. And if, of course, from our end, it's not easy to get to the level to be able to do everything. And that's the reason why we have specialties. We have other people that you can refer to, and there's other doctors and they can come back to you to restore or whatnot. But it makes our job more rewarding, basically. And it delivers better value for our patients overall your practice becomes, it defines your practice at a lot higher level once you start doing the implants. So you have more and more, people are living longer. People are just they're living longer. The healthcare is getting better, right? And so this is an old data. This is like 240. I think it's probably like more like 340 million or 400 million now, or whatever. I mean, yes, we lost almost 1 million people due to COVID in the U.S. alone, or whatever. But it's still a huge number of people that are missing teeth, and it's just constantly going up. But still, even to this day, most GPs are not placing implants. Most GPs are not placing implants because they're afraid. They're just afraid of doing it, and they don't want to invest the time and the energy and the money because unfortunately, life gets busy. I mean, things get busy in life, and so it's hard to do. But this is the fact. This rule, 80-20 rule, applies everywhere. You know, it's like, 20% of the population floss their teeth, basically. You know, so that's the reason why they have healthy teeth or whatever. But I would say majority of the patients don't floss their teeth. And so as dentists, we tell our patients, you should floss, but it doesn't matter how many times you tell them. I mean, if they did, if 80% of the patient floss their teeth, I think we kind of be out of business in a way, right? I mean, so it's a good thing that it's only 20% of the population that are flossing their teeth. It keeps us kind of busy and it helps us make money, basically. This is an old data too, but it's like 35 to 44-year-olds, you know, like the meat, like 69, 70% of them have lost their teeth, a single tooth or whatnot. And it's just climbing and climbing, because the population is it's not shrinking, it's getting bigger. The population is getting bigger and people are living longer. So this data is just it's gonna keep going up and up. And so from a productivity standpoint, the patient population or pool standpoint, it's just gonna get bigger and bigger and bigger, basically. And if the patients have known, let's just say, once again, we take the money out of the fact, if patients have known, like the 20-year-old I talked about, if they come in saying, I want all my teeth taken, I want dentures, but they don't realize this. They don't realize this is what happens to them once you lose teeth. If they know, if they are able to see this picture, they're like, I don't want that. Like, who would say they want that, right? Because they only see the pretty smile when they see it, right? They see the Julia Roberts smile when you smile. With the denture, I guess you'll have the same smile, right? But I mean, do you see this, you know, as far as this goes? And they don't see this. But if they see this and they're like, I wouldn't want that. Why the heck would I want that? And so it's just like patients just don't know. And today's patients, they, you know, Google, whatever, you have your phone, your internet's like readily available. You have it just at your disposal anytime you want, basically. That's the world. Information is just traveling everywhere. And so, I mean, you don't have to tell the patients about this. They just already know, because they do their research. And some of them look up implant surgeries on YouTube, whatever. I have patients that came in, they're like, because they were getting ready to get their implant placed, they're like, hey doc, I just watched this YouTube video. It looks kind of horrific, you know? Not a good thing sometimes, I guess, but this is what's happening. This is just what's happening in the world, you know? So as I said, advantages, you know, it's better longevity, and it's just, you don't have to prepare for a bridge. You know, you don't have to prepare the two next teeth, make them sensitive, make them painful, whatever. If you did enough dentistry, you know, you do a bridge prep on a patient, they're like, doc, I can't chew on this, whatever. It hurts, you know, after the bridge prep. It wasn't hurting me before, whatever. It's like all kinds of problems, right? And then also just the psychological effect. They get teeth, you know, it's like you get the natural tooth, it looks like a natural tooth, and it just functions like a natural tooth. And so it's a better aesthetic, overall just better choice. And it doesn't decay because titanium doesn't decay, basically. Yes, you can get periimplantitis, yes, you can get gum disease, but you have to take care of it. But and it's strong, it's very strong. It's not gonna break, basically. Their natural teeth are gonna break before the implant's gonna break. And so, and you don't get the bone loss, basically. It maintains the bone. It's a bone stabilizer, we call it. So for the patients, unfortunately, real world, I mean, yes, it does cost money. It's not cheap, you know, so there is some disadvantages to that. And for us as dentists, I mean, you have to train more. Unfortunately, dental schools, you know, they don't prepare you as well, which I wish they would, I guess. I don't know why they're still, I think the US is still bogged down on what specialists has to do this and GPs can only do this, which is not right, I think, as far as things go. I mean, with enough education, with enough training, I think anybody can do it, basically. So, as I said, it's a bone stabilizer. It just helps to maintain the bone. It helps to maintain whatever, everything, what was there. So God gave us teeth, everything for a reason. God gave us teeth, God gave us bone, God gave us gums, all this stuff. And once you lose it, things start to disappear. But you place the implant, you leave it there and, you know, let it heal, and you place a tooth there, you maintain what God gave us, basically. And so we're trying to preserve what God gave us in a way. And it has a very long-term proven clinical record. It's been around for a long time. And so, you know, it's like implants must be offered as a treatment option. This is Gordon Christensen, his quote, basically. And this is true. I think it definitely must be offered. You know, I mean, it's up to the patient to say no. And that's fine. You know, you can always say no. But you have to offer the choice. You can't just say, just because we can't do it or something, you can't do it. You can't just say, oh, you know, you should get a bridge here, or you should get a partial denture here, just because I'm not confident in doing it, whatever. Or, you know, you don't want to lose the patient, you don't want to have you don't want to lose the production, whatever, because, you know, they're going to have to go somewhere else to do it, whatever. That's not right, basically. And it's very successful. This is an old data. It says 97%, but I would say it's more like 98, 99%. So, I mean, out of 100 cases, you might get 2 or 3 failures. And yes, sometimes, I mean, in the world, crap happens. I mean, no matter how good of a stuff, how whatever best job you've done, it can fail. Things can fail. But is it the end of the world? No. I mean, if it fails, we can always replace, take it out, clean it out, whatever, do bone graft, and replace when needed, basically. But it can fail. But there's a high success rate. Once it's in there, if you follow the basic principles and you follow the basic guidelines, the implants has a very high success rate, basically. So, I mean, as I said earlier, back to the same thing. 20% of endodontically treated teeth lost in 5 years. This is from JADA, basically. Lifespan of a 3-unit bridge is 10 to 15 years. I mean, you've seen 3-unit bridges where you get secondary decay underneath the bridge, abutment, crown, or whatever, and it fails, basically. It just happens. You see it day in, day out. When you see enough patients, with dentistry that we do every day, this is clinically, we see this all the time, basically. And then we have more and more baby boomers that are suffering from missing teeth because the population, and the population is just growing. It's not just the baby boomers, but you have the generation X, Y, Z, whatever it is, all these whatever generations there are out there. And it's just growing. It's growing. It's constantly growing, right? So how do we dentists, as dentists, achieve these goals, right? And so this is where education becomes important. You have to learn. You have to keep up with what's today changing. Because you learned the technique once doesn't mean that you know it all. Because it's, as I said earlier, CBCT technology is changing. I studied from film-based dentistry. That was just what was available back in the days. And then we went to digital, and then now we're up to a more advanced level of digital dentistry. And so it's just constantly evolving. So we have to keep up with the changings of our dentistry, basically. And unfortunately, you have to invest the money and time. It's just one of those things. You have to do it. You can't expect somebody to take a weekend course and just know everything and say, oh, I'm going to start placing implants like I'm going to do all on X cases tomorrow or whatever. No, that's not the way how you should approach it, basically. But I mean, you take the steps. It's a journey. So I call it a journey, and I am still learning. I feel like I learn every day. I meet new doctors. I meet you guys. I pick your brains. I get information from you guys, and I learn new stuff. There's stuff that I don't know. There's stuff that you guys know. There's stuff that I know that you guys don't know. Whatever. It's just back and forth like a ping pong, just back and forth. We feed off each other, basically. And I think it's a great way to learn, But in order for us to know, basically, you have to know the basics. One of the basics, I mean, I'm here in LA, I don't know my points here. So, I mean, GPS is I think one of the best man-designed or man-developed innovations of today, right? Because I can get from point A to point B because I can get my phone up and just plug in the location, just hit directions, and it tells me where to turn left, where to turn right, whatever. If I make a mistake, it tells me go whatever a mile further and then make a right, whatever, whatnot, right? So this is the key to your surgery. You have to know where you're going, right? I mean, because there are vital structures in our body that we have to avoid, unfortunately, right? And so anatomy is the map for surgery. Unfortunately, you have to know it. You have to know it in and out. And so I'll start with the maxilla, top jaw. There's not much to the maxilla, basically. You have the anterior maxilla. In the anterior maxilla, you have the incisor canal. You have buccal concavities there, too, especially canine premolar areas, even in the anterior regions, very anterior regions. And then the posterior maxilla, you have, the bone is softer, and you have the sinus back there. And the sinus is just an air-filled space. That's all it is. It's nothing special. It's just an empty space. That's nothing more, basically. So the anterior maxilla, you have the incisor canal, which is the nerve, basically, right there in the nerve. And so if you're extracting anterior teeth, sometimes I just get the needle and just, drive it right in there, basically. We inject right in there. If the incisor canal gets in the way during an implant placement, which it does a lot when you place 8 and 9, we cut it and we remove it. We remove it and we graft it, basically, and we place the implants. You can't leave it because if you leave it and your implant hits it, the patient's going to complain of pain because it's a nerve, basically. So you have to remove it. But there's no consequences to removing the incisor canal nerve, basically, because it doesn't innervate areas where they really have sensation, in sense. But anyway, so the concavity is there. So when we place our implants, we have to be careful that you're not outside the bone, right? So one of the basic principles of implants, which I'll talk about in more detail later, but we want it to be in solid bone. So this is one of the analogies that I tell my patients. You need bone, right? You need bone to place implants. So imagine like to guys, a lot of the guys, I say, if you're gonna hang a 100-pound mirror on your wall, right? Don't you want the anchor to be in the stud, right? So you want to make sure you find the right stud, and you want the screw to be completely in that stud, right? Solid stud, right? If you're like halfway in the stud, right? You hang that mirror or whatever. Over time, it may be stable right away, but over time it's got and it may fall, right? Same thing with the implant, it's just gonna fall, right? And then so same thing. If I'm not in the stud, I place my screw in the drywall. You hang that 100-pound mirror on there, it's gonna fall right away. Basically, it's not gonna stay. So bone is important, okay? Bone is important, and so you have to make sure that this is where CBCT is important too, so you can see stuff, because what you see in the mouth versus what you see in reality of the bone anatomy and structure is two different things. So buccal concavity, I mean, of course you can feel for it. You can feel for it with your finger, and so I say the finger is the poor man's CT. I mean, I talked to Dr. Park during the surgery a couple of days ago. You know, I say like the lingual concavity, I say feel for it, right? I use the finger all the time. I put my finger in areas to feel for structures that I know that, you know, I want to be careful for, basically. So utilize it, you know, don't just stare at it, but utilize it, you know, get the feel of it, okay? And then also anterior maxilla has a lot of variations in the bone orientation and the teeth orientation. So anterior implants, I'll talk about more later, but it's more challenging, basically, because sometimes people have severe anterior flare, some people have less anterior flare, and some people have little anterior flare. And sometimes teeth are super buccal, sometimes teeth are right in the bone, basically. It just depends. And so this is why CBCT is so critical. This is why having the prior knowledge before getting into surgery is so important, basically. As I said, anterior teeth has a natural flare. It's just one of those things where teeth just have a flare, basically. You'd be surprised how much tilt there is in the teeth, basically. So like when we create the osteotomy, like on anterior teeth, we have to do it like 3 to 4 millimeters above the apex, basically, because of that flare and where the bone is situated. Did I not? I thought I changed my slide. Anyway, so posterior maxilla, bone is soft, it's D4 bone. But it's not always in the posterior maxilla. You have posterior mandible where the bone can be soft. And so this is why CBCT is also critical, because sometimes bone is very tricky. You don't really realize what you're getting into sometimes. But in the maxilla, we have the maxillary sinuses, and so I'll talk a little bit about the maxillary sinuses, okay? Because this is kind of important, because we always talk about, there's 4 different sinuses in the maxilla. You have the frontal sinus, the ethmoid sinus, the sphenoid sinus, but what's relevant to us is the maxillary sinus, basically, because that's the one that's going to get in the way. The other sinuses we shouldn't be dealing with, because if you're up in those areas, then you're in the wrong area. You're not. We shouldn't be in that area. So, what is the sinus? It's just an empty space lodged in our face, basically. It's partial, you know, like, and it just communicates with the nose. That's all. So that's the most important thing, though. It communicates with the nose. Okay, and so for us, it's pyramid shape, basically. It's pyramid shape, and the pyramid actually points out towards the sides. Okay, the pyramid base of the pyramid is actually towards the nose. So this base here is actually, this base is here inside towards the nose. Okay, so that's just the anatomy of the sinus that you want to be cognizant of. And it's about 12 to 15 milliliters in capacity, and the dimensions is about 23 millimeters medial to lateral, the depth. And like from anterior to posterior, it's about 34 millimeters. This is like the average size. And over time, it pneumatizes, meaning that it enlarges. It gets bigger with time. And then you have some septus. Sometimes there's sinus septus in there that it helps to compartmentalize the sinus, basically. And so this is the anterior. So this is the front of the face here. Anterior to posterior is about 34 millimeters. And then from the medial wall, which is towards the nose, to the outside face is about 24 millimeters there, or 23 millimeters there. So. And it's not, the functions of it is not well understood. We don't really know why it's there. But it helps to decrease the head weight, basically, the facial head weight. And also, it might absorb some of the shock of the trauma because it's air filled, basically. And so, and you know, the way how our voices come or resonate might be due to it, basically, depending upon the sinus. Because if you hear somebody that has a sinus congestion, you can immediately tell, right, when they talk, right? It's like their voice changes. And so that's one of the things that kind of, and you know, we breathe in air, and it also helps to warm, humidify the air as well too. So that's one of the things that it does. So, but why is it relevant to us? I mean, so as dentists, I mean, as I talked about, when we need to, I mean, if we're going to place implants, right, it's going to be in the back. It has to be in bone. But unfortunately, Number 14, is one of the teeth, like 6-year molars, are one of the first teeth to go, right, in the mouth, right? And sinus, it gets in the way. It just gets in the way, unfortunately, because as I said, we talked about the mirror and the stud, 100-pound wall, right? You want to be in bone, right? And unfortunately, the bone back here is softer. It's D4, D3 bone, and the sinus gets in the way, so you have less bone. So so it gets in the way. So that's why it's important to us. So we need to know how to manage it, basically. So sinus augmentation is often required, but there's easier ways. Like a couple of days ago, the Cresto approach. It's like there's an easier way. There's newer techniques that just makes it easier, basically. And they're less invasive. And you have to know your limits, unfortunately. But this is where training, education, continuously striving to get better and better. You gotta work hard. It's like if you want to get fit, you can't expect to get fit in one day, right? I mean, you have to kind of. And those guys, like I see people. I don't really exercise too much, but I mean those people that train, they're training constantly, right, all the time. So I mean, if you want to get better, you have to keep working at it. So once again, pyramid shaped. Okay, the roof of it, the superior border is towards the orbit of the eye. So we're not really messing with that area. Once again, if you're trying to go to the superior border of the sinus, you're in the wrong. We shouldn't be doing that. Okay. So what's the most important part for us is the inferior border of the sinus, which is where the teeth kind of sit on, basically on top. And so once again, same picture: anterior wall and the medial wall. And what's really relevant to us is this medial wall, basically, because the ostium is like right in the middle, but it's high up. It's usually very high up, but it's the communication between that and your nose. That's the channel where you communicate through the nose. And because of that, then when we do sinus augmentations, we put particulate graft into the sinus, basically. And so there's what's called a Schneiderian membrane. It's a membrane that helps to keep everything sealed, basically. And the sinus is a sterile environment, basically. And so we're violating it when we do any kind of lifts and stuff like that. So bacterial contamination, or keeping bacterial contamination, is very limited. It's very key. I mean, modern day antibiotics helps quite a bit. But you see these patients that have continuous sinusitis or whatever, it's hard to control, right? Because they can't get rid of the bacteria. So unfortunately, it's very important to do our surgeries like as sterile as possible, basically. And so this is why I mentioned about changing the protocol to keep things more sterile, right? So that we don't contaminate the stuff. And so when even though our dental offices are clean, we call it a clean environment. Sometimes you want to make sure that you're sterile, more sterile than clean, basically. And so wearing sterile gloves, not touching stuff with your sterile gloves. Number one, just and making sure that you're working in a sterile environment is very key, so that you don't contaminate to induce bacteria, basically. So the ostium is about it's like in the center. It's about 4 centimeters up high. Okay. So it opens into the middle meatus, which is the nose, basically your nose, and the actual opening is about the size of a standard implant, which is 4x10. But the tiny opening is only about 2.4 millimeters in diameter, basically. It does enlarge and shrink or whatever. But so what happens is, and you have what's called the mucociliary sweep, and so there's cases where we have during live surgical courses, we do sinus augmentations, and there's accidents where something gets perf, right? And then there's bone particulate in there. So we take a CBCT, and you see floaters, right? And then we take so we clean it out, and then we take another CBCT, and it's gone. Because it's already cleared by the mucociliary sweep, basically. That's how fast it clears things up. So it's very fast. It strokes at about 1,000 strokes per minute, basically. It sweeps things up. But the problem is that if you put large particulate graft material in there, and as it's trying to sweep things up to clear it up, basically, the body's trying to get rid of this foreign particle in there, foreign material in the sinus. You can block the sinus. If you block the sinus, they're going to have the congestion, the blockage is going to cause pain, pressure pain, and it's going to cause a lot of problems. So that's why it's important that that's why having the membrane intact during sinus lift surgeries is very key to success. So this sinus, that's how it looks like. And so if they do have a clog like this, if that happens, then you have to refer them to an ENT, because they have to go through the nose to try and unclog it, basically. That's how they have to unclog it, basically. And so using, like small particulate material is very important, and making sure that you don't perf the membrane is another important technique. And so sinus augmentation procedures and stuff like that is more advanced, and so we can talk about that later, but I'm just going to go over the basics. And so, but this is one of the key factors that you want to keep in mind, to prevent. And posterior maxilla, it's usually D4 bone. It's like styrofoam. It's very soft. It's very soft bone. Is it always like this? No, there's always exceptions. I've had cases where some guys have super strong bone, it felt like almost like D1, D2 bone in number 14, 15 areas. So you just never know. But once you do enough osteotomy, once you do enough surgeries, you get a feel for it. You get to feel the bone. Like when you're doing the osteotomy, you can feel the bone. But CBCT, you can actually see it beforehand because you can see the trabecular pattern within the bone. So it makes a difference when you see that, So this is why having critical data before you jump into the case is so important. And then next is the arteries and veins of the face, basically. So you have the facial artery that feeds into the PSA artery and the greater palatine artery and the infraorbital artery there, basically, of the face. Why is it important? So in the maxilla, if you're doing, like the greater palatine nerve is right there, and the artery and the nerve runs in similar patterns there, basically. It's run side by side, basically. If you're doing like connective tissue graft where you're taking tissue from the palate, if you cut that artery, you have a bleeder. It bleeds, you can see the blood just squirting. It'll just go. And so when you first see it, and you have them opened up, it's very it's scary almost because you have this blood where it's just bleeding like crazy, right? So pressure and time will stop, but you don't want to cut it. I'm just saying, so you have to be careful. So you want to know where it's at, and usually, and it's usually like on average palatal vault. You've seen patients that have shallow vaults or deep vaults, or average palatal vault. It's about 12 millimeters from the crestal ridge there. So if you keep that in mind, and it's usually around where the third molar location is at, So if you avoid that area, you shouldn't be going that far. Usually when we do connective tissue graft, we stay in this region, right? So we go from here like this, and then we cut here, basically. So that's the reason why. But you want to be cognizant, because if you're going that far back, you're going close to the soft palate anyways, too. So you should never be that far back anyways. And also the nerve runs in proximity. We give PSAs, MSAs, ASAs, infiltrations for like 3, 4, 5, 8, 9, 10, whatever, all the time. So this is common for us. This is nothing special for us. But in the sinus also, you have these anastomosis branches that we call it, and you have these arteries that are embedded in the cortical bone, basically, and so they run. So this is relevant to us because when we create our window for our lateral window technique for lateral sinus augmentation technique, it gets in the way, and so these are usually they're small, but once again they get cut when we do lateral window techniques. This happens all the time. And the blood, same thing, it just squirts. When you make a cut, it just squirts. You can see this like pulsating blood squirt just constantly going, right? So what you do, if that happens, once again, pressure. So you take a hemostat and just crunch the bone, and you have to really put a lot of pressure on there. You have to hold that there for like a good 2 minutes or 3 minutes or so. You have to hold that. You can't just let go after like a couple of seconds and expect it to stop, because these are a little bit bigger diameter. They're less than a millimeter, but they're still pretty decent size. And so if you see it like this, you can see this is pretty carefully dissected, but it gets in the way. And you can see it on the CT. That's why CT is critical before surgery, because when you see it, where you're going to create the window, you can see it on the CT. And so this is why information before surgery is critical, basically. And so here it says about half the time you can see it in the CT. The location where we're going to create the window, you can see it on the CT there, basically. But it's pretty high up. It's about 16.4 centimeters up from the crestal ridge. But that's not always the case, because a lot of times we're doing lateral window techniques because the bone they've lost teeth, they lost bone. So by the time we're in there, is in the exact location where we want to create the window. Unfortunately, that's what happens. So even though it's that high up, right? But it gets in the way. It gets in the way, And so crestal approach, like if you guys. I talked about posterior maxilla, you lose teeth, sinus pneumatizes, and so you get sinus exposure. And we talked about this a few days ago during the surgery, what happens if you're to the crest, So this bone here is usually a very dense cortical bone, okay? And so I actually sometimes go through the sinus because the bone in the posterior maxilla is D3, D4 bone. It's soft bone sometimes, and your stability of your implant is not the best with that soft bone. So I actually go through so I can engage that cortical plate, so I want good stability of my implants. So if you penetrate it's not the big deal. If you perforate, even if you perforate, as I said, it's a sterile environment, so you don't want to introduce bacteria in there. But once your implant gets placed, it plugs it back up. And this membrane, if let's just say you tore the membrane, this self-heals basically within a week. Basically, that'll heal. So it's not a big deal as long as you're not introducing any kind of foreign material like bacteria in there. Basically, it'll just heal over the implant. And here, they've done studies. I mean, even if it's less than 4 millimeters or above 4 millimeters, it doesn't really matter. Patients might get a little nosebleed because you're in the sinus, so that's one of the common side effects. And over time, if you take an X-ray, you might see some like thickening of the sinus membrane, the Schneiderian membrane. You might see that basically, but it'll usually self-resolve with time. So not a big deal if you do perforate. But that doesn't mean that you want to routinely just perforate the sinus. Like during the live surgery case, right? We went to the sinus, but we were very careful, and we purposely didn't perforate the membrane, right? And we even did a little crestal augmentation approaches, right? A couple of days ago. And so if you can, if you know the techniques, if you know how to do it, basically, you can always not violate the stuff. We still follow the basic protocols, right? And we still place the implants, basically. So, okay, now the mandibular jaw, the lower jaw. So what's there? I mean, obviously, the ramus, the body of the mandible, and you have the inferior alveolar nerve, and you have the mental nerve, right? So what's most critical, I mean, you have this what's called the mylohyoid ridge, okay? Everybody talks about the mental nerve, the inferior alveolar nerve, right? They're all worried about the nerve on the bottom. And yes, the nerve is very important. You don't ever want to cut the nerve, but you have to worry about this ridge before the nerve, okay? Because this mandibular concavity, which holds your salivary glands, that mandibular salivary gland, it sits right there basically. But something else sits there as well too. It's not just the salivary gland. You have what's called the lingual artery. This is a big artery. This is not like your small anastomosis arteries that run in your sinus, that I was talking to you about earlier. This is a bigger artery. So if you nick this is a big problem. This is from a dissected specimen of the jaw. But I mean, if you nick it, it's a big artery. It's a big artery that runs down in here. And so when you create the osteotomy so this is why CBCT is so important. This is why feeling the lingual concavity with what I call the poor man CBCT is your finger, right? You want to feel for it because when you drill down, you drill through that lingual cortical plate and you nick the artery, you're going to nick the nerve before you hit the artery basically. I mean, you're going to hit the artery before the nerve because of this, you induce bleeding in the patients. And what happens is looks are very deceiving in the mouth because like when you look at this X-ray, it looks like they have a lot of bone height, right? It looks like a lot of bone height, right? But this is my patient, right? Look at this. Look at the lingual concavity. Some patients have a very high lingual concavity where it just comes up, and everybody has different anatomy. And so this is why CBCT information, the data is so critical. This is why it's so critical prior to surgery because you have to see it before you get into it. So when you look at this, it's like, oh yeah, a 10 millimeter implant is perfect, like 5 by 10, whatever, 6 by 10, whatever, it looks perfect. You see this, it's like, I misthought that one. Yeah, I misthought that one for a second there. No, 10 millimeter implant is not perfect for this site, no. And so you have to be careful, and this is what happens. And there's been a case, it was an oral surgeon that placed the implant actually, it was a long time ago now, but patient went home, he was bleeding, like he was having like swelling. And so he called the oral surgeon and he's like, hey doc, I'm swelling. It's like my throat's swelling, my area's swelling here. What's going on? And he's like, oh, you'll be fine. It's gonna go down in a day or two. Patient passed away because it blocked the airway because the swelling kept on. It's just the bleeding wouldn't stop because as I said, it's a big artery. It's a big artery down there and you don't want to violate it. So this is one of the structures that you want to avoid. It's not a small artery down here. It's one of the bigger branches. And so before the nerve, you have to worry about the artery. So you have to feel for that lingual concavity and be careful for that basically. So, and you have a lot of vascular, it's rich in vascularity down there, and so you want to be careful for it. You want to make sure that you don't violate any of these areas. Incisive canal, we're never going to really lay a big flap on the lingual. At least you shouldn't. I don't really understand the reason why. I mean, and so but just know that it's there basically, okay? And this is one of the terminal branches, so you can still cause some bleeding in these areas too if you are laying a flap back there. So, but it's pretty far down below, and as I said, you shouldn't be really laying a flap down here because, I mean, the oral surgery that we do, it doesn't involve much of this as far as things go. So, And then the nerve. I mean, we deal with the trigeminal nerve all the time. You know, when you give blocks on the lowers, that's, you know, it's always there. The inferior alveolar nerve, the long buccal nerve, the mental nerve, and the incisive branches. This is some of the stuff that we inject every day. This is what we do day in, day out with our bread and butter dentistry. So this is nothing new, but just to review for you guys, I mean, mainly what's important for us is just the lingual nerve, the inferior alveolar nerve, and the mental nerve. Basically, those are what are in the buccal nerve, you know, and it just supplies the teeth, gums, the mandible, and, you know, all these areas of the face, basically. And so the lingual nerve. So I talked about this a couple days ago during the surgery. You know, when I'm in the posterior maxilla, number 17, number 32, or even number 18 when we're doing surgeries, I always say make a buccal hockey stick incision. So the incision is not like straight, it's oriented towards the buccal, and it's like a hockey stick. You know how a hockey stick comes down and it looks like this, right? So we always make a buccal hockey stick incision. Why? Because sometimes when you look at the architecture of the teeth, it feels like or it looks like you're on top of the ridge, right? But you're not. Sometimes you're not. In the posterior area, you'd be very surprised. If you do a lot of wisdom teeth extractions, you'd be very surprised how much sometimes things curve out, whatever. And so I always say make a buccal hockey stick incision to avoid the lingual nerve, because if you cut it, their tongue area is just going to be numb for the rest of their life, basically. And so you're going to create this morbidity on the patients, unwanted morbidity, and it can lead to lawsuits and all kinds of headaches and problems, right? So you want to be careful. So flap design is very important, you know, when we make our cuts, right? When we make our cuts. So it's like it's like because of sometimes the nerve actually, and from a clinical standpoint, sometimes the nerve comes like here, like in this area, basically. And there are cases where it's really, really close. So I always make my incision hockey stick, buccal hockey stick, never on the ridge, back there when I'm back there. And then you have the long buccal nerve is what we give as far as the, you know, when we take out teeth in like 17 or 32. So that's another nerve that's there. And this is one of the main nerves that we're always worried about. It's the biggest branch in the mandible. It's the inferior alveolar nerve. And it crosses from lingual to buccal near the first molar region. That's where it crosses, basically. So a lot of times it's more lingual, like in number 17, 18 area, or 30, like 31, 32 area, basically. And then as it gets to 30, that's where it comes to the mid, and then it starts to cross. Because it wants to come out the mental nerve, right? So you have to remember the mental foramen. So that's the way how it moves. And so accurately mapping this out and determining where it's at is very critical for our implant placement. This is once again why CBCT data is so important. So this is why I feel more confident if I have a CT scan of a patient before surgery versus, you know, like with, you know, other than just having a panel or a PA because of this, you know, because a lot of times you can't see this. And so, you know, the canal is about 3.4 millimeters wide. The nerve itself is about 2.2 millimeters thick. And it's just a bunch of sensory fibers. So it also holds like the vein as well and the artery in there as well too, within the bundle, within that canal. But the nerve is the main thing that takes up the space there. So, and then the most common shape is the elliptical arc shape, basically. The elliptical arc shape. That's the most common shape of the nerve. You have the linear shape, the spoon shape, and the turning curve shape. But the most common shape is the elliptical arc. The same thing with the 80-20 rule, basically. So 80% of the cases, you'll see the elliptical arc type of the nerve. And once again, you have different positions of where the nerve is, basically. You know, and sometimes it sits more lingual, it can be right on the tooth or whatever. So when, like wisdom teeth extractions, if it's right on the nerve, sometimes, if the patient's like under 21, it's usually not an issue. Like you won't really have post-nerve issues, but if they're older, because the bone and the tooth are a lot more fused, basically, there's a higher chance that you can get post-op nerve issues, basically. So in those cases, we do what's called the coronectomy, where we just take the crown portion of the tooth off and just leave the root, basically. So that's what that's called for. So, but there's also like bifurcations of the nerve where the inferior alveolar nerve splits. It divides into two. And so once again, panoramic data, this is kind of showing on panoramic data, but you know, CBCT is so important, so you can see that, you can see all that, so that you're not violating something that's unwanted there. So I mean, there's lots of variations in the mouth. You know, God has given us whatever with lots of variations. And so in order for us to be prepared for our surgeries, that, you know, and these variations, whatever, CBCT data is so critical, so critical. So what do you do? I mean, so once again, we try and take CBCTs. I mean, there's different ways to do surgeries. We have what's called guided surgeries, basically, and I use guided surgeries, and I always double check the length. And then also, you know, on your surgical kit, right? Even on the surgical kit, I always say check the shank, because on the shank of the drill, you have your length. It's laser engraved on the shank of the drill bit, because your assistants don't always put the burrs back in the right spot. So just because you pick a 3 by 10 millimeter length drill out of the kit doesn't mean that's a 3 by 10. That can be a 3 by 15, and you don't realize it, and you just go in with it, and you're going at 1,000 RPM, and you just go straight down with it. You probably hit the nerve, basically. It only takes a split second. It's very fast. I mean, when you're doing surgery, like it's really fast, and so you want to double check, triple check. You know, I always say go slow and I mean, you know, like during the surgical courses and stuff, some of the doctors, they just want to kind of move, they just want to kind of go and go, and some people just want to go really, really slow. But it's like I say, it's not a race. It's not a race. I mean, we're just trying to finish. You want to do quality work, you know. So you want to be efficient, you want to be fast, but you also want to do quality work. So you want to check everything, make sure you're safe. Remember that a lot of our implant drill bits are actually. So if this implant drill is designed for a 10 millimeter implant, right? They're not 10 millimeters actually. They're like 11 millimeters. They're longer. And a lot of the doctors that are just starting out, they don't realize this. And so they have like these, what's called the catch drill. These are like with the stoppers, these are exactly 10. If you're doing, so you have to remember that. And this is by like a Nobel system here. And see, this is for the implants, a millimeter longer than the drill bit's a millimeter longer than the actual implant, right? So even though we're placing a 4.3 by 10 or whatever, or by Nobel, right? Or 5 by 10, when you're creating the osteotomy, you're creating it to 11. You're not creating it to 10. So if the nerve is at 10 or 11, and you think, oh, I'll be fine with the 10 millimeter implant, right? And you start drilling with the 11 millimeter drill, there's a chance you're gonna hit the nerve, basically. So you want to stay within the zone of safety, we call it, and I'll talk about that more. And then the mental foramen. So that's another nerve that's where the inferior alveolar nerve exits, right? And so usually, I mean, depending on the race, like Caucasians, it's between the premolars, first and second premolars, basically, like 20-21 area or 28-29 area, right in between there. But on Asians, it comes out a little bit earlier, next to the second premolars there, basically. So, and mental foramen sometimes have what's called an anterior loop. It comes out and it creates an anterior loop, and sometimes it doesn't. So, once again, CBCT data is very, very critical to you know. And there's different variations. You have the Y branch, you have the up loop branch, or you have the no branch, or you know the looping back branch or whatever. So it's very critical that you know where this is at to prevent damage, basically. So I always say, you know, the variations you have to measure many times. And so we want to follow the basic protocols or the principles when it comes to implants. You want to have the implant surrounded by bone. So we say buccal millimeter, lingual millimeter, you know, like whatever. So you want to be surrounded by bone, and you want to be away from the nerve as well too. So these are some of the things that we want to keep in mind when we're placing implants. So you always want to measure. I say 3 times, 4 times. Measure many times before you cut. You know, because, and this is why CBCT data is so important. But even with CBCT data, when we're doing surgeries freehand, when you think you're here, you might be here, not here, and so your measurement might be off. You know what I mean? So this is why it's very critical that you really study the CBCT before jumping into the surgery. People say surgery is easy, right? People say, oh, this is an easy case. It's not an easy case because there's so many variations. There's so many there's so many things that you don't see, that you don't really realize, because what you thought you saw on the CBCT sometimes is not what you are in the mouth, because your orientation is not always that perfect. You can't be perfect, and this is why surgical guides sometimes is necessary. Surgical guides are critical. So we call it the zone of safety, and so you want to stay 2 millimeters away from the most anterior loop point, because you want to be away from it in case there's any variations, and you don't know if you're just a little bit off, basically. In the zone of safety, and a lot of the planning software, like here, even with Ray's 3D, on-demand 3D software and stuff like that, the planning software actually has this safety zone window, they call it. So when you have the implant, you have the safety zone window, and so when we place the implant, it creates that safety zone for you so that you can stay away from these vital structures. That's what that's there for. So we need to utilize the tools of today to help us to our benefit.
Also has the impression and model scan protocol as well. And the next one we have, lastly, is called the Ray Scan Studio, which is similar to the Ray Scan S. It's a 20 by 20 scan, but this one also has a facial camera, which you're able to scan patient's face in 3D format. And using those data, you're able to superimpose the CT scan, the intraoral scan, and then the facial scan, merge that all together and create like a full digital patient. You can see in the picture here, you can see how we have the impression scan, the X-ray scan, the facial scan, and we kind of merge it into one.
So I'm sorry to interrupt, but the future of dentistry, you know, if you think about it, with this technology, you're able to fabricate a digital denture, and you can actually correct the cant. You know how when you get a denture back from the lab, your cant's off, whatever, like your vertical's off. Like this, you can see everything because you can see the face, you can see the vital structure, you can see the structures that are there. And so it gives you a lot more information just on the screen, basically. Like, you know, so it's not, they're working on it, they're still, you know, evolving, they're still changing, but that's the road that it's heading towards. And so it's not just like from a lab work standpoint, you know, this is valuable information that we can have, basically. So.
Yeah, so yeah, definitely. So these are all the products that we have for CT that we have in the company. And then I'm gonna go move over there and I'm gonna kind of show you on actually how our unit works and what kind of protocol we have here.
I'm gonna follow you since I have the mic, I guess. And since it's already hooked up, I don't want to disconnect.
Yeah, no worries. Okay. You're more than welcome to come and see it for yourself. Yeah, I don't bite. Okay. So this is the Ray Scan Studio, the top of the line model that we have that I mentioned lastly. So you can actually control the unit using a touchscreen as well as a remote control. So I'm not sure if you guys knew, but we used to be a subsidiary of Samsung. So we kind of based the technology off of Samsung technology. So we created like a remote feature to kind of control everything. So this actually comes in handy because for those with tight spaces, you're not able to access the touchscreen. You can actually freely come over to the other side, control everything with the remote control. So that's pretty handy. And the unit emits 4 different colors. See here, right now we have a blue color, meaning it's just on a standby mode. And we have a green color, meaning it's ready to expose. Yellow meaning it's exposing. And red means there's some kind of emergency stop has been activated. So if I press, there's a red button here.
Yeah, emergency stop. Yeah.
So if there's some kind of hazard coming along the way during the scan, you can actually press this and it emits like a scary red light. And then I can actually release this and it turns back to blue. Yeah, so that's that. And then I'm going to show you on the software side here. So this is our software. It's called SmartDent. So all our software comes in one package with the unit. So everything's included. This is called a SmartDent. This is where you'll be able to create patients, view images, get to the acquisition page, everything here. This is like a one-stop portal for everything. So I actually created a patient here already, so I'm going to show you how our protocol looks like. So if I click on the camera icon, and I'll just focus on CT side today. So although it's a CT, you can do everything like the panel and everything, but today I'll be primarily focusing on.
Is this Eugene?
Yeah, this is. So I created Eugene's patient here. So I'll show you. So we have multiple protocols here. I'll briefly go over what these protocols will be here. So as soon as I clicked on the acquire button, it's going to automatically position itself to a patient positioning mode. So once it stops moving, you'll see that please wait message will be gone. Yeah. And so here we have all the patient information. So, and what's really cool about our software is, based on the age of the patient, it automatically adjusts the radiation level.
Exposure,
yeah. Yeah, exposure level. So this, you do not have to even touch it. So based on the age, it will automatically adjust on itself. And here we have the protocol name. Here we have a temperature meter. So let's say you take like 30, 40 CT scans in the span of like 30 minutes. It's a lot, but eventually the unit will overheat, and this will kind of give you a warning and it will kind of let you not take any scans for like 5 minutes to cool down, so that you can prolong your health of your X-ray unit. Yeah, so we have multiple protocols here. We have like a regular jaw scan, which is the 10 by 10 full jaw scan. You can still capture the third molar. And here, it tells you all the information here. We have the jaw, the field of view, the size of the scan, and the exposure level, the power level. And here we have a fast scan mode. So for those like the elderlies or for those who cannot stand still, if there's movement, there's always going to be distortion in the image. So we created this mode so that they don't have to stand long, and you'll still get the image that you're able to diagnose with. And we have a larger field of view scan, which is 16 by 10. It kind of captures all the way to the airway. So for those who are bigger, then a lot of
Sleep apnea,
sleep apnea.
for appliances and stuff like that.
And here we have the full facial scan, which is a 20 by 20 full skull head. And there's 3 different modes for the 20 by 20 scan. Here we have a regular X-ray, and here is called the scout scan. So this one has a camera for the facial scan. So it will actually take a picture of the front of the patient's face with the X-ray. So it will save that as a one merged data. And then here we have a regular smile scan, meaning this will be the 3D facial scan, primarily used for smile designs and such. And here we have the endo scan. So this one consists of higher resolution. So when you're doing endo cases, you do need higher resolution to see the canals and such more clearly, including fractures. So here you can actually choose the specific area where you want to radiate. Like for example, I want the right premolar with the maxilla or what's called mandible side. But I'm not actually sure if I'm going to capture the exact area, right? So if I actually click on this little icon here, the rotator will move to to the desired area, and then it's going to emit the blue light that I was talking about earlier. So it's going to emit a blue light, and so actually, kind of stand in there. So you can kind of see, if you come closely here, you can
See where it's pointing, the blue light, where it's pointing to, yeah.
So you can kind of see where I'm actually aiming. And then using the information, let's say I don't like that field of view, I don't move it somewhere else. I can actually use these, using these arrows, I can control the size of the scan. So you can see how it's moving. You look on this side.
Yeah, so the blue light is getting wider or
So I can actually
taller or wider, yeah.
adjust it. Yeah.
If you ever ran into a calcified canal, even on a premolar, like number 4 or 5, and you can't find the lingual canal sometimes, after you made the access, sometimes there's times where I take a CBCT scan of it to orient myself to where, because sometimes you're struggling in there. It takes you like 30 minutes in there because you can't find the canal, and then you take a CBCT, and you can find it because you can orient where you're off, like just if you're too buccal, too lingual, or whatever, or too mesial, and you can redirect to find the canal basically. So it's a huge benefit having it. Technology is improving, so our dentistry needs to improve to match the technology basically, and this is one of the ways that we can utilize the technology to help us.
Okay, and I'm gonna go back to my previous page. Okay, so that's how we would take the endo scan. We also have TMJ scan where we can primarily focus on the TMJ area to see the location of the condyles. And here we have a sinus scan. We'll focus. So all the positioning is the same. The rotator will do the rest to choose where you want to scan. And lastly, we have the airway scan for sleep apnea, sleep studies, etc. So when we actually acquire a scan, I'm going to go and cancel this. So when we acquire a scan, it's going to save it into our software, and you'll see an image here. And we also provide you the 3D viewing software for you to see the image and do your planning. So we provide you a software called On Demand 3D. This is the top of the line CT viewing software. So here we have, let me actually show you.
One thing that I noticed with the RayScan software versus some of the other ones, right? If you look at this model, you don't see any scatter. Like like what I said, I have different offices. I have more than one office, and I have different brands. I recently got a RayScan CBCT machine as well too, but I have a Plan Mecca as well too. But the Plan Mecca, I mean, this image is good on the Plan Mecca, but this image, there's a lot of scatter. If the patient has PFMs, whatever, implants, like, cause I do a lot of implants, so there's a lot of implants, and then so you see a lot of scatter. There's like a lot of distortion scatter, so it's hard to see this, right? But when you look at their software, it's crisp. There's implants here, but it's crisp. It's just clean. It's super clean. And so this is one of the noticing factors that I noticed right away with the RayScan software, basically. So.
Yeah. So yeah, I mean, glad you mentioned that. So basically, all our CT scans are applied with a metal artifact reduction filter, meaning there will be some kind of distortion, but we reduced it so that it's very minimal. So you're still able to diagnose all the teeth around the implants area or metal affected area. For those who are familiar with how to view a CT, we come up with the 3 different modes, where the coronal view, the axial view, and the sagittal view. Meaning you can look from the back to the front,
the side,
bottom to top. So you can actually, and I can actually freely adjust.
And it's fast. There's no like delays either. It just moves along with you wherever you want to. So
yeah, so you can actually align it, and you can actually see how you want to see it. So if you move one box, other boxes will also apply, so that you're seeing the right location in multiple view. From here, you can actually do your measurements. Plan your implants. Let me show you here. So the software will also initialize the arch, and it can automatically draw the arch to kind of see in a panoramic view format and a cross-sectional view here. So let's say if you're planning an implant, doing the measurements, and our implant libraries are all here. Our libraries get updated pretty often. But let's say there's an implant library that you don't see, then you can always contact us and we can add in the library for you as well. And then what's really also cool about this software is we also have a way to also measure airways for sleep studies. So I can actually trace the airway, and then it's gonna kind of give you a volumetric measure on how tight or how wide the airway is. So it kind of gives you even a color coding format, like red means it's pretty narrow there, and there. This is Eugene's scan.
Yeah.
But, sorry, I don't want to put you on the spot. But, sorry, this is how you're able to measure your airway. And also for those who are endodontists, we can actually. We created a tool where you could see the canals in like a endoscopic format. And let me show you what I mean. Like, let's see. Maybe if I want to go over, like, let's say, sorry. So I'm gonna zoom in a little so you guys can see the canal better. So I can actually zoom in. So obviously you want to do this in after taking the endoscan, but since we have the full skull scan, we'll use this. So when you actually zoom in, you see the canals here, right? So I can actually trace the canal. Let me see. Like I can actually trace it. And if I double click. So I just traced the canal, and I can actually change this into like an endoscopic format here. Let me see.
I think you just have a little section because it's on airway right now. So.
Yeah. I can actually reset it. Sorry. Yeah, it works a lot better when you're doing the endoscan. Zoom in a little more. So you really want to be accurate when doing these. Go too deep. So, okay. So it's a little small, but you can actually, this is actually inside a canal. And you can kind of go through, but I haven't traced it much. But you can actually, if you do an endo scan, you can actually go through the canal and see how wide or how narrow even the canal is. Hopefully this will help you when doing, your root canals and such. So yeah, that's just the basic gist of this software. But you can do a lot more like surgical guide planning. And using this machine, since it's a 20 by 20, you could even do a thing called a 3D cephalometric tracing for those who are orthodontists.
So what he means is you can take a CT and you don't have to take a lateral ceph. Like you don't have to have a separate lateral ceph. You can extrapolate from the CT a lateral ceph from the CT. So.
Yeah. So with the unit, everything will be prepared for you after the installation. We can train for you. So we'll go in full details, when that happens.
Brian's going to introduce a little bit more about the RayScan software. He's going to talk about facial recognition, facial scanning, right? Or actually model scanning. This is kind of cool because when I first got this, so you guys, I don't know if you guys know about intraoral scanners and stuff like that. Everybody knows, I guess a lot of people are doing digital dentistry these days, and so you got intraoral scanners. But RayScan has a feature where you can actually take an impression if you don't have an intraoral scanner, and you can put this on the CBCT machine itself, and the machine will scan this impression. You can have an STL file out of it. So if you guys are doing surgical guides, where you guys want, and the way how surgical guides work is it marries the scan, like the model of your, like the lower jaw or whatever, if you're taking number 18, whatever it is, it marries this to this DICOM file, which is a CBCT scan file. So it marries the STL file and the DICOM file becomes 2 in 1, and then that's how they create the surgical guide. But this has this feature where you can take an impression, and if you take a previous impression like this and have the scanners, the CBCT scan the previous impression, then you can get a very accurate data where you don't have these problems, basically. Because I talked to the class earlier about garbage in equals garbage out. And so if you guys don't give the lab a crisp, clean data where you got a good impression of this and you have a good CBCT data, then your guides will fit very nicely as well too. But if you guys are trying to do this intraoral scan in the mouth where you guys are doing a bad scan of the mouth, and then you give the lab the data to fabricate your surgical guides, you're going to have problems where the surgical guide might not fit right or it might be off, basically. So this helps to eliminate a lot of those kind of problems. So he's going to go over this in more detail here just a bit.
Yeah, so basically, not only you can actually take scans of patients using the RayScan, you can also scan models and impressions. We created this protocol so that there are still a lot of people who does not own their own intraoral scanner. Then they're still used to the conventional impression method. So we create a method. So we have this little protocol here, platform here.
And if you guys have ever scanned the full arch in the mouth, it's technique sensitive, number one, and there's a bit of a learning curve, number two. The software, even though it's intuitive, if you rely on the software, that's where you get to have problems of distortion, relying on the software, basically. So this kind of eliminates some of those factors because we are so used to this as far as taking impressions goes that this is second nature to us, where you know what a good impression looks like. But sometimes us dentists, because technology is new and we still don't know a lot of stuff, you don't know what a good intraoral scan looks like sometimes. And so you send the data to the lab for a surgical guide and you come back and you're like, this stupid lab made my surgical guide wrong. It's not the lab. It's you guys. Whoever made the surgical guide or whoever did the intraoral scan was probably off. That's where it was off.
Yes. So so therefore, so we were able to kind of raise even a higher quality because impression data is really important for labs to receive. So we captured that. So you would actually you can actually instead of the trimmers you can actually hook this up and scan the impression itself. Like remove everything, just hook this one only, and then it'll do its own scan like how you would scan a patient, and then it would actually save into our software here. And it will automatically convert from a DICOM to STL format automatically.
So intraoral scans are STL files, we call it, okay? And then the CBCT scans are DICOM files, DICOM files. And so the way how it works is it takes the two files and it stitches them together. Like the Trio software that they use to make your surgical guides and stuff like that is what they use. These files are what you need to export out to give to the lab for them to fabricate your cases. If you guys send your implant cases like a digital scan using a scan body, it's usually an STL file that you're sending them to the lab. So.
Right. So yeah, so I've already scanned this impression myself, and then if I actually open the scan, you'll have a STL format of this impression. Now, you can actually, send this impression as a whole, but we could even go further by making this into a digital model. So as soon as this loads up,
So instead of, for some of you guys, if you guys are thinking about investing in an intraoral scanner, I mean, of course there's limits of what this can do versus what an intraoral scanner can do, but this can actually take over some of the intraoral scanning problems that you have with just one CBCT machine. So that's something that you guys can take into considerations.
Yeah, so this is actually the impression that we just scanned here. If I just want the area, if I just brush off the area that I like for example, I'm just highlighting on the area of the desired position that I like.
So this is all from the CBCT machine. This is the scan of this model here from the CBCT machine. And that's how it looks like on the software, basically. So this is what you can extrapolate out of the software, basically. Mm-hmm. And it's actually taking a physical CBCT of this impression. It's not taking a actual, like a picture. It's actually taking a CBCT of it, like a three-dimensional, like your mouth, like or jaw. It's taking a CBCT of the model, and this is it's extrapolating out. Just like we can see the jaw, like the bone and all that stuff in the CBCT, this is exactly what this is doing. Right.
So as soon as I highlighted the area, this can actually convert this into a 3D digital model. So you guys are more used to like pouring the stone to have a physical model. Now you keep a digital file of it, and you will be able to send this file over to the lab, and they can work using these files.
So it's like your intraoral scan. If once you scan it, this is what it looks like, and on the software as well too, basically. So it's the same thing. So.
And then, and not only you can create your own STL, you can also import your like a STL that you got from somewhere else, like from a different lab or from a different office. So I actually have a STL file that I received here. So after so if I actually drag the STL file over to this viewer, here now you have an STL file over this abutment, and if I just keep transferring over, so there's multiple STL files that were already merged together, like stitched together to make the full case. And if I actually kind of finalized product, but it basically once it's finalized, you'll receive a file back from maybe the lab, or you'll receive a printed version of that, and then you can actually physically see how this can do, and then if you have your own printer, you can print out your own model as well. And yeah. So once it's finalized, you'll get something like this.
So like if you guys are ordering a customized abutment or whatever, or a crown from the lab, they're taking the STL file basically. That's what they're doing, and they're complete. All the stuff, like a lot of the stuff these days. A lot of the stuff these days that we get back from the lab is usually, a lot of them is done model-less, basically. They're done without a model. It's all done on a computer screen. So a lot of the lab tech guys are not really doing like stone, yes, they are doing some die stone work and stuff like that, but it's not really on stone anymore. It's all just click, click, click on a mouse on a computer. So, I mean, a lot of the guys are more tech-savvy guys that are just in there designing your compute, like, the crown, the abutment, everything, just depending upon the gum level and all that stuff. That's how they're doing it on a screen. So this is the way, like the new wave of dentistry, basically. It's just going towards digital. And unfortunately, it started already, and it's just kind of getting better and better, and people are constantly striving to get better with it, and it's changing. This is one of the things that's changing, and this is how they're utilizing their technology to help all of us, basically. So.
Okay. And then, so that's how we would, that's how you would be able to utilize a ray scan, so you can get digital models and to be able to send it over to the lab, all the necessary information. And the next thing I'm going to actually explain to you about is one of our other product called the Ray Face. which is a 3D facial scanner by itself. So this is the model that I'm going to be talking about. It's a desktop basically scanner where you just the patient sits in front of the desk, in front of the scanner, and you'll be able to actually capture. It will be a stationary scan, and it captures multiple images and make that into a 3D model. So I'm going to actually show you here. Doctor, you can be the volunteer. Let me see. Let me pay attention. So.
Male. Just select male.
Okay. So I'm connecting the software now with this product, and then it's gonna get it ready. So it actually flashed up here. I wish the screen was next to each other, but you'll see if you take a look here.
And you can see the picture.
You can see the live feed of the camera. It gives us a guideline on how you want to position. So we're gonna. Oh, you want to try taking a scan? Yeah. Okay. So here we have a little red dot here, right? You can just be looking at that. And then we're going to use that screen to kind of adjust it right here. So now we can step a little more forward.
And you can go down a little bit more.
Oh, yeah.
A little bit more down, yeah. Down further.
Oh, that one?
Yeah, down. Down more, yeah. Okay.
And then
Maybe just a little bit up, just a little tiny bit up. Okay, that's good.
if you scooch it more forward, sorry. Yeah, a little more. Yeah.
Maybe just a little bit. Which way? Left?
Oh, a little bit to the left. Yeah. Okay. So
Maybe up just a hair, or I mean, there you go. It's a little bit off in the.
a little more forward. Yeah. Okay, thank you. Okay, I think that's close enough. So you just look straight into the red dot, and I'm just going to capture from the computer. So, give me a big smile. So this is called a smile scan. Okay, that's it. And then we just took, yeah, that's it. Yeah, all good. Yeah. So if you take a look here now, we just took a smile scan here. It's primarily mainly used for patient consultation or to design a smile. So I'm going to go ahead and click on the image here. A little off, but so I'm converting now. Now this file format is called the OBJ file. It's similar to the STL, but it's a 3D facial object file that you can use to stitch your CT DICOM data and your intraoral scan STL data as well. So here now we have the 3D model here of the patient.
Cool.
You can actually rotate it and start doing the smile design here. And yeah, so this is one of the other products that we have, and yeah, and then we're trying to utilize like an all-in-one package so you can have a full function, fully digitally customized office, So yeah.
Yeah, because it's kind of very valuable because you're not looking at like a separate picture and like a like a picture photo, right? And then the CBCT or whatever, and whatever, the STL file. So you can marriage everything together kind of, and you can actually work with everything, like the full facial, whatever structures and everything. So it's kind of cool as far as not from a cool factor, but like everything, when you design anything from a tooth to a crown or whatever it is, you can do lots of different things, like whatever appliance that we're trying to design, so. Thank you, Brian.
Thank you.
So we're going to go back to our bone, okay? Bone types. Back to the basic implant course here. So, we get Mish. He's passed away. He's one of the four founders of dental implantology, basically. He classified the bone density into 4 different types of bones. You have the D1, D2, D3, D4. D1 bone is very, very dense bone. D2 bone is a little bit dense bone. And D3 bone obviously is a little bit less dense bone, and then D4 bone is like very soft bone, basically. So So there's a bit of a difference. Like D1 bone has very little cancellous bone, basically. So it's a lot more cortical bone. Cortical bone is like white bone. So if you ever lay a flap and you irrigate the bone out, right, with some sterile water and you suction it up, you'll see it's kind of white. It's just very white. And so you know the cortical bone is there. That's cortical bone. And when you first drill, like for your osteotomy, when you create into it, it feels very hard. It's solid. It's very solid. So it's good. It creates good stability over implants. And then the softer bone, which is like the cancellous bone, it's more porous, okay? And there's different types of porosities within the cancellous bone, basically. That's what makes the bone types different from D2, D3, D4, basically. So D2 bone has more, it's more denser as far as that trabecular pattern versus like the D3 gets less dense and then D4 is almost like just empty space. So that's why you want to be, you have to know what type of bone it is, number one. And CBCT is very critical because you can see some of the trabecular patterns within the bone on a CBCT scan. So once again, it's from a wood, like, comparison to a wood, like dense bone is like cortical D1 bone is more like oak or maple wood, if you guys are into woods, whatever. D2 bone is more like white pine or spruce wood. And D3 bone is like balsa wood. It's softer, it's like pretty soft. And D4 bone literally is like styrofoam. It's very soft. I mean, it's super soft. So, and this is how this is another classification. They call it the Hausfield scale, basically. And so the D1 bone is very little bit of cancellous bone, so it's a lot more denser. So there's some advantages and disadvantages to each of the bones, basically. So D1 bone is super dense. So like having super dense bone is always not the best because you have to remember your vascularity is within this. Within this area is where the vascularity is, right? And so, and in our body, our body's ability to heal is all dependent upon the vascularity. So when you cut somebody open, you bleed. And the reason why we bleed is because as we bleed, it creates all these, it releases the cytokines, all these stuff. And as it bleeds, you form a clot, and that clot is what helps you heal. That's the reason why PRP, all this stuff was invented, because, and we spin it down to try and create those growth factors to help stimulate healing in that area up there, basically. But if they don't bleed, it also doesn't, they don't heal. So like on the lower jaw, if we ever need to do any kind of GBR techniques or like where we do guided bone regeneration or anything like that, you have to sometimes decorticate the bone. You have to create these holes in the bone to create these bleeding points because it doesn't bleed. And so the bone doesn't just, when you graft it, it doesn't heal as well, basically. So that's the difference, like, in the types of, when you have too much cortical bone, it's also not the best, basically. So it's always a balance, right, between what's good, what's the best and what's not the best, right? So D1 bone has the greatest like bone to implant contact. Yes, it's very strong. And so if you do mini implants or anything like that, like on the lower anterior mandible, sometimes like the mini implants just like one drill, one tiny skinny drill, and then you drive the fixture in, okay? And as you're driving the fixture in, it's tapping into the bone. But so for instance, I had a case where I was doing a mini implant. Bone was so dense that the implant stopped driving. And then so if you need to back up if that happens, right? And if you try and force it, what happens? What happened in my case, the implant driver and the implant head, where it's like a hex head that fits on the mini implant, right? Because these are like one piece, either ball, whatever it is, it got damaged. And the implant wouldn't back up, it wouldn't. So I had to trephine, I had to trough around the implant to get that mini implant out, basically. And then I ended up placing a regular implant. But anyways, that's how dense the bone is sometimes in these type of D1 bones. But also, it also not as vascular, so it doesn't heal as quick. You think that it's good because you have good stability of your implant. You think that, oh, it's awesome, my implant's like super stable. It's like 80 Newton centimeters, it's great, but no, it's not always the best. It's not always the best. So in osteotomy, sometimes we have to over enlarge the osteotomy. So that's why they have these for cortical bone, they have these separate extra drill to enlarge the cortical plate, basically, for that purpose. So D2 bone is actually the best bone. D2 bone, because you have a nice balance between cortical plate, a good cortical bone, and good balance of cancellous bone, where you have nice, thick, dense trabecular patterns. And usually D1 bone is in the anterior mandible. D2 bone is sometimes in the anterior mandible, mostly posterior mandible, sometimes the upper maxilla, anterior maxilla, that is. And it has a lot of vascularity, so it's good. Our implants get nice and stable, and it induces bleeding, and so that's good. So it helps to heal that implant, basically. It creates that osseointegration, which helps the implant to heal, basically. So D3 bone has a lot of vascularity, a lot more vascularity, but unfortunately, the cortical plate is thinner, number one, and then so it's not as strong, but it's not bad. So a lot of the posterior maxilla, like sometimes even in the posterior mandible, sometimes you have D3 bone or whatever, and so you'd be surprised how many patients in the posterior mandible have mandible. You think mandibular jaw is hard, right? But they have D3 bone or even D4 bone in the posterior mandible. Like you'd be surprised because all they have is just a very dense cortical plate, and the rest after that is the empty space there basically. The trabecular pattern is hardly not present there, and so you think that the lower mandible you're safe, but sometimes you can have dropped implants in the mandible because of this factor, and so you have to be very cognizant. This is why CBCT data is so important. You have to study and examine the CBCT before getting into your surgery because you don't realize it, but you think that the bone is strong, and you just kind of do your osteotomy and just place the implant, and then the implant drops and it just disappears, and you're like, what the heck happened? And this is why. Some of this reasons is why this happens basically. So D3 bones, a lot of times, when you have this data, we under osteotomize the site, number one, and then when we place the implant, we place a bigger implant than the actual hole. The actual implant protocols, the systems, the drilling sequence is designed to under osteotomize the hole, number one. But we even under osteotomize even more, basically, on D3 bone or D4 bone, so that the implant creates the stability as it's driving it in, basically. So, and once again, D4 bone is like a styrofoam, so you have to really under osteotomize the site, and so you have to be careful with D4 bone because of how soft it is. And so the way how the maxilla resorbs with time, it's this is the way how we lose bone, basically. It's in an upward motion on the maxilla and an inward motion. So the jaw bone kind of goes up like this and then inward like this. And then the lower jaw, it's a little bit different. It actually goes down and outward. So we get, unfortunately, because of this, when the patients lose their bone, like that witch that I was talking to you about, the upper jaw kind of collapses right inward, and the lower jaw kind of comes up a little bit, so they become pronectic. Like they look like they're serial class 3s, even though they're not class 3s at all. Basically, that's why it looks like that. So, and they've done some studies, and so remember the upper dentures have like the palate, but there's more surface area, right? So it's a greater surface area where it sits on, and because of that, it has more square inches of space where it puts pressure on the bone. And since the teeth are missing, it creates more pressure points, and because of that, the upper maxilla resorbs faster than the lower jaw a lot of times. But is this always the case? It's not always the case, but this is what studies have shown, that this happens. Once again, this is the way how the upper maxilla, the way how it resorbs upwards and inward, and the lower, and then the posterior maxilla, same thing, is upwards and inwards, the way how it resorbs, the bone resorbs with time. And then the mandible is more of a downward and outward kind of in the shape, as the way how it resorbs there. So like in the posterior mandible, when they've been missing like 18, 19, or 30, 31 for a long time, they usually have a pretty wide ridge because the top has resorbed and then it comes down, because this part kind of comes like this, more like this, and it starts to widen basically. But the problem is the nerve gets in the way, even though they don't have enough, like if they lose a lot of bone. So even though they have, so this is a classic shape of the way how, when you lose teeth there, and bone with time. So what do you do? I mean, if you don't have enough bone, right? What do you do? I mean, so this is where bone grafting, augmentation procedures, like we talked about sinus augmentation earlier just a little bit, but just, all kinds of different types of, there's so many different variations of augmentation. There's like the ridge split, there's GBR, guided bone regeneration, there's, all different alternatives. And they even have like mini implants these days, right? And I talked a little bit about mini implants, but you have mini implants, and there are cases where mini implants are very useful. I mean, I talked a little bit about my grandfather earlier, and it's short time frame, I didn't have time, and one of the benefits, I can immediately load, and he goes home, and if something fails, we can take one out, put another one next door, or whatever. It's not a big deal, right? Unfortunately, nothing has failed on him, actually. It stayed the whole time, whatever. But I'm just saying, people are like, oh, I don't want to do minis, or whatever. I mean, but I think there's a place and a time for it, And there was like a case where I did a full arch case, and I needed to stabilize her dentures, or whatever, because until they healed. So I placed like 4 or 5 mini implants, and just put them and had her wear her dentures, and she was happy for the time being until her regular implants healed. So there is a time in where it's called for. So I wouldn't. So this is where I say use the tools to our advantage. It's like there. So use it to your advantage for the patients. So once again, like socket preservation. So key to good surgery, key to being a good implantologist, I would say, is being a good surgeon is number one, like incision. Everything starts with an incision, right? Making good cuts, making good closures, and then being able to take out teeth well is very, very important. As I said earlier, I have like 3 practices. I have multiple associates. I even have not everybody can take out teeth. People say they can take out teeth, but not everybody can take out teeth. And when I say take out teeth, I mean atraumatically take out teeth, because you want to preserve the bone. You don't want to, if I cut the whole buccal plate off and take whatever, anybody can take out teeth. That's something that you can do. But knowing how to take out teeth with preserving everything is a different story. And being good at it and efficient and fast is where you got to work on your clinical skills. And I can't teach you all that in one setting, or I can't, explain all that in one visit, basically. But knowing how to cleanly take out teeth, knowing how to, close the patient up properly, those are very key factors to doing good, leading to success, basically, down the road. What question do you have? No? Okay. So, just basic socket preservation, basically, bone graft. You take a tooth out, we pack bone in there. And this is like a membrane that they place on top, and you suture, a figure-8 suture back there, basically. But so it requires extractions, and then you have like the GBR, guided bone regenerations. You have bone block grafts or whatever. Like GBR has a bit of a clinical track record now. It's a newer technique, basically. It hasn't been out that long, but it has a pretty decent clinical track record, and it works. It works very well. And so knowing how to do good bone-guided regeneration is important for success, because if they don't have it, you have to build it up. You have to know how to build it up so that you can place your implants, basically. And even if, you're placing the implant, the bone's damaged or whatever, then we do GBR in conjunction with the implant to build the bone back up at the same time. So once again, guided bone with titanium mesh, the titanium membrane and stuff. And this is how you build up bone, basically. This is the way how we build up bone. If they don't have it, you want to build the bone back up. And then there's like the block graft, the sponge bone graft, or there's lots of different blocks. Or you can even take it off the ramus or whatever, and so you can, or even here in the anterior mandible or whatever. So there's different areas or locations where you can take the bone. Yeah, and then there's ridge split. Ridge split is great if you have a big wide ridge or whatever. Big long spanning ridge. So never do ridge split on a single tooth location, because it's very difficult. It's actually very difficult. The narrower, the smaller it is, the location. Like if you're doing a single tooth extraction site, and you're trying to do a ridge split, that's very difficult, because you're going to break the buccal plate. If the buccal plate breaks and you're trying to do a ridge split, you're pretty much done. You have to flip over to a GBR. And you have to hope that that bone is stable enough that you don't lose it, basically. But anyway, so if you have a longer spanning area like this, ridge split is, one of the benefits of it is it heals very fast. Like if you do this ridge split, 3 months later, you can restore this case. That's how fast they heal. So, it's technique sensitive. It's very technique sensitive. But if you know how to do it, it works very, very well. So, you split the ridge. We put the implants in. The implants actually acts as an expander during the time. So the bone gets expanded. We fill it with bone, and then you place a membrane on top, and then we close them up, basically, right? And then they heal beautifully. The bridge it widens right away, basically. The vascularity. That's where it comes in. The cortical bone and the cancellous bone just kind of starts to, the vascularity starts to fill back in, and then it forms bone, basically. So it's a very very quick procedure to try and gain bone, basically. But it's very technique sensitive. It is very technique. You break the buccal plate, it's done, basically. So you have to be very careful, gentle, and you have to know what you're doing in essence. But it's a way to gain bone, and quickly. So. But unfortunately, there's some morbidity, because you have to do a big flap. You have to do all this. You have to have a piezo unit to be able to cut, or you have to use these drills or whatever. But so there's some technique. It requires more training, basically. But it's there. It's there. Okay. And then obviously the sinus we talked about a little bit. Sinus augmentations. This is how we add more bone to the posterior maxilla. So ridge split is mostly in the lower jaw, but you can do it in the upper jaw, like upper anterior areas too, where we do ridge splits too. But in the sinus, we do either lateral window technique or the crustal technique to expand or lift the membrane and then add more bone, basically. So the crustal technique is obviously less traumatic, because you don't have to lay a big flap. And I do some of my cases like with the tissue punch. I go in, create the osteotomy with the casket, whatever, and then I do my sinus lift, and then I pack the bone, and I place my implant. So the patient, they leave, and then I place the healing abutment, because I get good stability to the implant. And then so they go home with no suturing, and there's very minimal pain. And so the patients are very happy. So if you guys can try to deliver cases or do cases without minimize your trauma, right? the patients are happy. And if you can do that to your patients, you have more patients that are returning back to you to get more implants done if they need another one down the future. If you cut them open big and you hurt them, they usually don't want to get another one done, basically, because it was a traumatic experience, So, like, you talk about patients will come into you and they'll be like, oh, I had this wisdom tooth extraction and the dentist was on my chest, like trying to take this tooth out, whatever. And then they get all afraid and they're like, I don't want anybody to take out my teeth anymore, or something like that, So, if you can deliver cases more atraumatically, that's better, right? Or if you can do cases more atraumatically, it's better. And so, use the techniques that we have today. I mean, the tools and the techniques is all available. You just have to learn how to use them. And of course, yeah, it takes time to get to that level, but it's like it's available. So once again, like single tooth extraction, bone graft, you have bone damage, we can still build that back up. There's ways, and these, there's lots of ways to do stuff. I mean. So for us, I mean, for the beginners, I guess, that are out there, you have to start somewhere, right? So where do you start? I mean, so usually premolar sites are usually the best. I mean, if the nerve is far away and stuff like that, and they have plenty of bone, those are like the single sites, like these cases. This is a good case to start like this, with plenty of bridge, plenty of bone. Those are the start. You have to start somewhere, right? You got to start somewhere. So you can't just, you have to jump in somewhere. But so these are like the easier cases that you want to start with, okay? You don't want to jump into like a sinus case on your first case. That's not the approach. Or like an anterior number 7, 8, 9, 10 case where the bone is like whatever, it's like not the best case. But so I mean, so the anatomy from we talked about the maxilla, the nerve, the sinuses, the concavity, and so you got to build up. You got to build up on your what you know. So there's still more. There's still more, but you got to utilize the techniques that we have. CBCT, obviously, as I keep stressing the importance of CBCT. It's so critical. It's so critical. Like I feel like I'm naked if I jump into a surgery without a CBCT, a prior CBCT of the case, basically, because now I rely on it so much. Like, but when I didn't have it, I didn't know So the thing is, you don't know what you don't see. You don't know what you don't know. That's the funny thing, and you just don't know. People don't even know what they don't know, basically, because you don't know it. And so, it's one of those things where when you see it, it like opens your eyes. It opens your eyes to what like the whole new world of things, basically. And everybody has different anatomy. Everybody has different variations of everything. And so you got to be able to see it, basically. So even when I treatment plan a case for an implant, I don't just say implant. I say, I'm sorry, but we need this special x-ray. I need this x-ray on you so I can analyze your bone, analyze what you have, your nerve, your vital structures. I don't want to hurt you. I don't want to violate any of those things and cause any kind of like permanent damage to you, So I need this x-ray. Even though there's a fee, you tell them this is what the fee is or whatever, I need this information because if I'm going to properly treatment plan a case, I need this information because how do you know if you're going to just need bone graft, you're going to need membrane, whatever, with the implant? You don't know. You just don't know. And as I said, use the tools of today. I mean, this is a CAS kit by Hyacinth, but so there's kits out there, or there's tools out there to help you utilize stuff so you can create atraumatic surgeries. There's we talked about a little bit about this, spacing the parallel guide kit, how to space your implants, right? How to properly position your implants, basically, because that's one of the biggest struggles that we have. Even me, if I don't have this, I have a hard time visualizing where I need to be for my first initial pilot drill on my osteotomy, basically, right? If you have 18, 19, or if you have 18 and 20 and you're placing number 19, you want to be obviously in the middle of that, whatever, buccal wing going right in the middle there. But when you don't have that, you're just doing the distal extensions. And let's just say you're placing 18, 19, 20, whatever, in all three of them, right? You need the spacers to be able to space these out properly, basically. So use it to the advantage. And then obviously there's the surgical guides that I talked a little bit about earlier. And so surgical guides help. I mean, so one thing about surgical guides, so I want to stress, garbage in equals garbage out is so important, okay? You guys need to give good data to the lab, okay? And surgical guides, just because you have a hole doesn't mean that it's always easy. Just because the drill fits in the hole, it's not easy. In the mouth, people have limited openings, okay? And then also, you have to be careful because when you irrigate, in your regular freehand osteotomies, when you go down, the irrigation cools the bone down. But unfortunately, the surgical guide blocks a lot of the irrigation out, basically. So you don't get that water in there. So what happens, I see people, when I do using surgical guides, I train a lot of other dentists, and then we do these type of cases or whatever, and they're just trying to force it as hard as they can, whatever, into the bone. And I always say, even during our live surgeries, or whatever, I say pumping motion, gentle pumping motion with your osteotomy, with the handpiece, right? Is to pump the water into the osteotomy as you're going, right? But even with this, they're just like at 1,000 RPM, just going, wah, and then you can hear the metal shavings off because you have to be very parallel as you're going into the hole, okay? Even though there's a hole there. But the thing is, they think that there's a hole, so you just start drilling like this, and then you think that it's just going to automatically straighten out, and it's just going to go in. It's not. It doesn't happen. You start to damage more bone, and then you start to create heat. And so it's technique sensitive. So just because you have a surgical guide, you think that it's like, oh, I can just do this case simply. Yes, it makes your life easier. You can do the case simpler with the surgical guide. But it requires a couple of things. Number one, as I said, good scan, good CBCT, good intraoral scan or intraoral impression, one or the other, whatever, so that when the lab makes your surgical guide, they're matching this data together to create a nice, crisp, good fitting surgical guide. Number two, us as a surgeon, when we go in, we have to make sure that we're going in very parallel to the holes that's designed for it. And you want to go slow. You want to go slow. And lots of pumping of the irrigation. You want to irrigate that socket because what happens is you put the implants in, so let's just say everything went well, right? But you're the doctor, the beginning doctor, you did your surgical guide. You just went, or metal shavings everywhere, right? 1 month post-op, you see the X, you take an X-ray, you start to see necrosis, you start to see this radiolucency around the implant. What happened? Bone necrosis. That's what's happening. It's heat. Heat's causing bone necrosis, and then your implant's not healing right. And you're like, why is this happening? The doctor's like, I wonder why this is happening. It's because you're not following the basic principles. You have to think. You have to really think. It's engineering. There's a bit of physics, right? But so when I say use the tools of today, but use it properly too. That's what I'm saying. Use the tools of today very properly. So, and as I said, you don't know what you don't know, and you really don't know what you don't see. And so knowledge is power. Having fast, great knowledge is important. Like people think, oh, I can just do this guide, the surgical, I can just order a guide, from the lab and just do this case, And so, but they if they don't have proper training to do surgical guides and they just kind of start drilling at it, this is where you run into problems or whatever. And what if something does go wrong with the surgical guide or the case and you don't know how to back up out of it? If you're because this is where freehand case, knowing how to freehand the case is so important, right? So this is where knowledge is very important because you think that you can rely on a surgical guide to do everything for you and then something goes wrong and you don't know how to manage it. Crap happens every day. We have our good days, we have our bad days. You don't know. You never know. We deal with people. We deal with live people. We deal with everything, right? In the mouth, there's saliva, there's blood, there's the cheeks, there's the tongue, whatever. Everything's in the way. So, so there's a lot of variables that we can't control. So, knowing before getting in is completely different than not knowing and just jumping into it. So, as I said, checking the bone quality. This is very important. You can, when you order surgical guides, the CBCT, the data, right? They utilize that to tell you exactly what type of bone there is in these areas, basically. On the mesial, distal, whatever, you're gonna have the mesial. It says that this is D2 bone, and then on the whatever, on the lingual, there's D3 bone. So this is reading the data off your CBCT, basically. So this is where you already know before you even get into it. Because you can look at it from the CBCT and they can analyze what type of bone it is. So knowing is very, very important. And then remember I talked to you a little bit about the mandible. You can have implants drop in the mandible like this, basically. This can happen. This happens during our live surgical courses, basically, because the bone is just soft. You think the bone is dense. You have nice, strong cortical plate, but then after that, sometimes it's just air. It's just air. You have to be careful. It's obvious, implants drop in the sinus. It happens. It can happen. How to manage it is it's a different story. You have to know how to do it if you're gonna just jump into it. So you don't really want to just jump into stuff. That's why start taking baby steps. Nobody learns how to walk right away, right? You got to learn how to crawl before you walk, right? So we got to learn how to crawl first, and then we start to walk, basically, right? And so, but you have to know. You just have to know, and to know you need the data. You need the information before you start your cases. So that's where things are very, very important. So use it to the advantage. Use what's there. Use it to our advantage. Use what's there because you really don't know. You look at an X-ray, you look at a PA or whatever. You think it looks good, right? You think it looks good, but teeth sometimes are situated very funny. They're very buccal a lot of times, And so you take this tooth out, you take a PA, you take the tooth out, and I'm like, I'm going to place the implant. I was told that I'm going to place my implant lingual, right? So I'm going to go in and place my implant. I go lingual, and I'm out the buccal plate, right? Because this is very short here, so your implant's at least going to be like this, right? So once again, you don't know what you don't see. And you look at a PA or a panel, that's all you see. It's not ideal, basically. So when you look at it, it's way out buccal, right? You're gonna damage the buccal plate. And then once you've created the damage, you have to try and repair it. And it becomes more difficult now, basically, because you created an unwanted damage that you didn't think that was gonna even happen, basically. So even if you know, like this is not very ideal, because where is this supposed to point towards? It's like it's not even towards any of the biting forces, right? And so this is why CBCT is so critical. And knowing and looking and examining and planning the case is so critical. It's so that you know, so that you can see it and you know it. Because then you don't know how to treatment plan the case either. Like what I said, you see something, you see a parl, you see like a periapical radiolucency on X-ray, and you're like, oh yeah, we'll just clean out the granulation tissue and just do a graft. But then look, if you look carefully, there's no buccal plate. So what are you going to do? You're going to have to place a membrane then. You can't just graft that and just expect that to heal, right, or whatever. So then it's additional cost. I mean, so if you didn't add that to the treatment plan, and then during middle of surgery, you're like, oh, Mr. or Mrs. Jones, so I just noticed I took your tooth out. Your buccal plate is gone. They're like, what is the buccal plate? I'm like, and you'll be like, oh, your facial plate of your bone is gone. Are you sure it wasn't you when you took the tooth out? Like you just damaged it or whatnot, or, But if you see this, you can show it to them. So you can show it to them and say, this is what's going on, So this way it makes you look good too. It doesn't make you look bad. So if it's done after the fact, it makes you look bad. Either you do it for free, or you're eating the cost, or whatever, But if you try and add it on, tack it on later on, patients are not going to be they're not going to be happy. I mean, it's like you go to buy a car, whatever, and you were told that it's going to be $50,000 for a car, whatever, and then all of a sudden you come out and you're like, oh, your car's going to be $70,000. They're like, where'd that come from? It's like it's not fun, right? So you have to know. You have to know. But so a couple of things that we always want to keep in mind, okay? So implant dentistry, factors that we need to, obviously bone quality, okay? And there's different sizes that fit in different locations, okay? You don't want to place like a 7.0 implant for number 7 or 8, whatever. It doesn't fit there. Diameter, I'm talking about diameter. And your implant positioning, angulation, obviously implant depth, and then implant to implant distance, implant to tooth distance. These are critical factors that you need to be cognizant of, keep in mind. These are so all these things play a role from a restorative standpoint down, crown down, basically. So like a central, usually, it's like 4.5 millimeter in diameter. Lateral incisors like 3.8, whatever. Molars 4.5 or greater, basically. I prefer bigger implants in the back molars, because if you place a skinny implant like a 3.0 or 3.5, it's very tiny, and then the emergence doesn't look right, number one. Number two, with the strong bite forces, it can fracture the implant. If you ever have a fractured implant in the back area and you need to take that implant out, and it's floured, let's just say the implant's floured, right? It's not easy, because you have to trephine or you have to trough around that implant to take it out, so you have to create a lot of damage to be able to, and you're probably, what's going to happen is you're going to have to take that implant and place another implant in there, but if you create more damage to the bone, then it's going to be a lot more challenge, basically. So those are things that you don't want to do. So if you start with the good principles, then, and try and maintain the balance of the principles, then you won't run into those type of problems, basically. So anterior mandible obviously is thinner, it's smaller, so even 3.5, 3.0 sometimes, or whatever, even minis, whatever, in the anterior mandible. It depends on the location, basically. And premolars 4, 4.5, and molars 4.5 or 5 or bigger, basically, once again, in the lower jaw as well, too. So, and then obviously from tooth to implant, we want to have at least 1.5 millimeters from tooth to implant distance. And from implant to implant, we say 3 millimeters, basically. And then you want buccal lingually about 1 millimeter bone, basically. So you want the implant to be completely 100% surrounded by bone. That's what we want. That's the most ideal. But if you look at it from a like a prosthetic standpoint, the central fossa, central fossa, central fossa, central fossa, right? So it follows the central fossa, right? From a tooth standpoint, right? So if you look at it from a restore standpoint, that's where it should follow. Like, so I visited a lab here in LA, and I was looking at some of the cases, and the screw. So some of the these cases, I prefer to do most of my restorations screw retain. Okay, so I might be a little bit lingual, I might be a little bit buccal or whatever, but I'm usually close to the central fossa. But I've noticed some of the cases at the lab, they're like way mesial, like tilted like this, bad angulation number one, way buccal, where the screw hole is coming out the buccal cusp almost like here. Not right. Bad placement, basically. And so, or way lingual, like here in this area. Not right. I mean, so you have to keep this in mind. You have to remember that implant should be restoratively driven, not from the implant up. You have to think from implant, like the crown down, basically. We need to think that. But we also want to make sure that we maintain these principles, okay? Like the implant distance history. So it's hard to, like, when you look at it like this, it's easy to look. But when you're in the mouth, you don't have anything. You're like, oh, how? Like, so I don't know. Like, depending upon the size of the implant that you're gonna place, like, what distance is this supposed to be? What distance is this supposed to be? It's hard. It's hard to calculate. It's not easy. So there's easier ways, but I mean, I'll talk a little bit more about that, okay? Anterior regions, you never want to be too buccal. If you place an implant too buccal, it's aesthetic standpoint, it's nightmare. It's detrimental nightmare. It's like the worst thing. You can err on the lingual, because you're going to have a cantilever buccal and still have a good aesthetic outcome. But if you're too buccal, like, you can't hide the metal. You can't. It's hard to hide the metal. It's unaesthetic. And then also the space that you need, right? So minimum space that you need as far as things go between the teeth and the implants. You have to make sure that these principles are maintained. You don't ever want to lose these principles. So you have to always think of it from a restorative standpoint. And then you have to remember the biological width of our natural teeth. So the question that a lot of people ask is, how deep am I supposed to go? How deep am I supposed to go? And so it depends upon the buccal plate. Like, especially on anterior cases, and as I said, it's very tough, but you go to the depth of where the buccal plate is here. Like, so you want to match this, because you have to remember the biological width is always going to be there, right? It's biological width. You have to maintain it. You have to maintain it, because if you violate it, tissue's not going to be happy, things are not going to be happy, you lose it, basically. So, and then you have to remember, you have to also be cognizant about the prosthetic height, right? I mean, ideally, you want 9 to 10 millimeters of prosthetic height, basically, because you have to have enough space for the crown, you have to have enough space for the abutment, because it's all about physics. If you're, we have zirconia crowns now, whatever, and titanium abutments, but the problem is if these are too thin, patients bite, it'll fracture. Things will fracture. Something's got to give somewhere, And you have these big burly guys that are strong with big fat, square jaws that can, grind the heck out of teeth. You put like a 5 millimeter height, whatever, tooth crown with the abutment on there. So your crown's only less than a millimeter. It's gonna break. It's not gonna stay. It's not gonna stay. So you have to kind of keep that in mind, So in the back, like number 1831 site, I was talking about one case a couple days ago where I was like, oh, I'm worried about the occlusal clearance, right? So I said, use a UCLA abutment, use a gold crown, basically. One piece screw retain, gold crown, basically. It's all one piece. So you don't have to worry about nothing fracturing, nothing coming out, So sometimes it's called for. I mean, even though aesthetically it's not the best looking thing, but it will last, it'll function. It'll last for a long time, so. And then obviously, you have to have inner arch space. You have to have sufficient space. 7 millimeters for just a single tooth in the posterior, whatever. 8 to 10 in the anterior region, and then like the all-on-X cases obviously requires more. So that's the reason why for the bone reduction and all that stuff, because there's whatever appliance that you're going to make, there's bars or whatever whatnot that is required. So, and then obviously proper angulation. This is very, very important. I notice when I'm training people, it's like they don't get a grasp or a picture of the proper angulation of how implants are supposed to go. I think it's very critical that you see the picture. Once you see the picture, I think it becomes easy, right? But the problem is people don't see the picture. People just don't see the proper angulation picture, how it's supposed to go. And so, the force is always in the mouth. It's always towards the functional cusp. It should be pointing towards the functional cusp. Because why? Implants like a direct force up and down. But if you put something forced like this, where you're putting the implant like this, it doesn't like it. It doesn't really like it. All-on-X is a little bit different. Like you're like, well, how come all of those all-on-4s or whatever is like, you have implants like this and then you have implants here though, right? But the balance of force between this here and this, with the multi-angled abutment like this, it kind of offsets this pressure here. So that's the reason why it actually likes it, because it's not a single standing implant that's holding that in that direction there. So, but a single implant, it actually likes the forces up and down, not sideways. Okay, so this is why for long-term success, having properly placed implants is beneficial. It's so critical, so important. So once again, proper angulation, and don't, try not to be satisfied with something. You're like, you take an X-ray and you're like, oh, that looks halfway decent. We can go with it. up your game. Try, step up. Try to do it. And there's ways to correct it. There's ways to correct it. Like even with your first drill, second drill. Remember the parallel guide thing we're using and stuff like that, right? Most people skip steps. Most people don't do it. And even though they're not very good, they still skip the steps. They shouldn't. You shouldn't. You should try to, maintain the basic principles all the time. Okay. And the length. Usually lower jaw, the bone is very good. It's dense. It's good bone. We talked about D1, D2, D3 bone in the lower jaw. So lower jaw, since the bone is dense, 8.5 millimeter, 10 millimeter length are sufficient. You don't have to be a hero and place like 13 millimeter or 15 millimeter implant on the lower jaw. It's unnecessary. It's not required. Why do I say it's unnecessary? Let's just say you place a 13 millimeter implant on the lower jaw, and the bone is like a D2 bone. And we talked about earlier placing like a skinnier diameter implant, and crap happened, and you have a flowered implant, 13 millimeter length implant or 15 millimeter implant. Let's just, you need to remove that. How easy you think that's going to be to remove a 15 millimeter implant in the lower jaw when it's integrated, when it's osteo-integrated, and it's flowering or something that's cracked? It's hell. Even if when you're trying to remove a 10 millimeter length implant, it's hell. If you guys ever done it, it's hell. It's not easy. You have to remove quite a bit of bone to get to it, basically. And even when you're like almost 2/3 of the way down onto the implant, like on 10 millimeter implant, you'll be like, it's not budging. It's just not budging. And you can't use one of those implant removers to remove because the implant's flowering. So there's nothing to grab onto. So you have to trephine or create, trough around the implant to try and remove it. It's hell. And because it's hell, because as I said, if you can remove the buccal plate, you damage the bone, it's not a big deal. You just whatever. It'd be easy, but that's not the case, right? Because we have to replace the implant again with something else. So it's hell. So don't be a hero. Like 8.5, 10 millimeter length is perfectly fine for a lower jaw. Upper jaw, so usually, the bone is not as dense, okay? So the longer, 11.5, whatever, 13, if needed, is possible, but we have the sinus, all this stuff, structures that are in the way. So fatter and shorter is always good, like 6 by 8.5, whatever, in the posterior mandible. Maxilla is very good, 5 by 8.5, whatever, stuff like that, So shorter and fatter if you can. And then we talked about with regular teeth, the crown to root ratio is kind of important. You don't want the crown to be like 2-to-1 flip-flop, right? But with implants, it's irrelevant. It's irrelevant. You don't have to worry about it. So this is why I say on the lower jaw, you don't have to have a 15 millimeter implant because you're whatever. It's not necessary. It's not necessary. And once again, studies have shown that implants crown to root ratio is irrelevant almost, basically. So it doesn't matter if it's flip-flop or whatnot, you can still make it work on the lower jaw or whatever in the jaw as far as implant to crown ratios. In anterior mandible, as I said, the space is pretty tight. So sometimes it requires minis. It requires mini implants. This is where minis play a role, whatever, because you don't have enough space. You can't, like in this, you can't place, even like a 3.0 implant sometimes is too tight. It's too tight for placing there. So you just have to sometimes you have to use the skinnier implants down there. Unfortunately, that's what's required. So calculating space, right? We talked a little bit about calculating space. How do you calculate the space, right? So you're looking at it on paper, and so it's easy. So whatever, this is a 4, whatever. So 3, 3, 3. When you calculate this, it might look easy, but in the mouth, it's not easy, right? So what makes it easy? How can we calculate where should be 1.5, where should be 3, right? So I always say you got to look at it from tooth down, okay? Not from implant up. You got to look at it from the other way. So think of yourself as being a lab technician, right? So think of yourself as making the crown on the tooth. Before you look at the bony structures, whatever's underneath, think of the tooth being on top of there. Think of imagine the tooth going on top of that implant that you're going to be placing. That's how you should be thinking. That should be your mindset. That should be your visual that you're getting with this. So it should be prosthetically driven. This is very important. This is super important. So if you think of an average molar, it's about 10 millimeters, basically. Average molar is about 10. Premolar, we say about 8 millimeters in the width. And so if you think of it as restorative driven down, right? So what's 10 minus 5? It's 5, right? So your center of your implant, like your implant positioning, should be 5 millimeters from here, basically. And then that should be your first hole. It doesn't matter what fixture size you're placing, because you can place a 5, diameter 6, diameter 4.5, whatever. It's still going to be centered in that restoration. So it'll be in the central fossa. It'll be center of wherever that restoration is, basically. That's how it should be driven. That's how you should be thinking, basically. Average width of teeth. This is pretty like a kind of an average summary, basically. And so in the posterior, but this is very relevant, like in the back, like, because you have like number 18, number 31 as we placed a couple days ago. And you're like, when you try and place the implant, you're like, where do I start my first hole, right? It's always kind of it's tough. It's tough. And if you're off by even a millimeter, right? If you're off just by a millimeter, you'll have like either a mesial or distal cantilever, one or the other, basically, where the implant's like kind of off-centered. It's not the most ideal. So this is the easier way to look at it, basically. It's like if you look at a molar, 10 millimeters, so you should be like 5 centered, right? If you have a premolar that's like 8 millimeters, it should be 4 centered. If it's 7, whatever, it's 3.5 centered, basically. That's how you should think. That's how you should think as far as your calculations go. And you also want to make sure that we talked about the basic principles, right? You want to have bone everywhere, right? 1 millimeter of bone surrounding the implant there. So you always want to follow the basic principles, right? In the anterior region, once again, you always want to be more lingual and you want to maintain that buccal plate, the thicker buccal plate. So always, if you're going to err on the palate, never on the buccal. Because if you err, and then also the depth, you don't want to be too deep, you don't want to be too shallow either. Because this is why anterior cases are a little bit more tougher too, because of this, So if you're too deep, if you're too buccal, this is what happens. And so, and it looks ugly as heck. It looks very, very ugly. And so if you have a patient that has a high smile line, and they try to smile, like you can do like pink porcelain like this, and you can't, it's hard to mask. It just doesn't look right. It just doesn't look right. So it's a nightmare if that happens, So don't ever err towards the buccal, So I'm going to tell you a story. I had a case, so I do like cases, courses in Indiana. And so one of the doctors came and took a surgical guided case in Indiana. And so she did the case, right? And then so she's like, so this case came back to me. So she brought the case to me afterwards, and I was looking at it, and she's like, how am I going to restore this? I said, why? What's going on? And so the implant is kind of like, is there like a multi-angle abutment that I can use to try and angle my implant back down? And then, and she said, I did the surgically guided. And so I was like, well, good. It must be good, right? So once again, back to the doctors, right? It's us ultimately that's responsible to accept the case and approve the case. So remember, a lot of times the technicians, I'm not trying to badmouth anybody, but I'm just saying the technicians are just looking at the bone, okay? Whatever. They're not really looking, sometimes they're not looking at it from a tooth, right? And so the implant, the way I was planned, was positioned way buccal because the bone was like this, whatever, the ridge. So, but it should have been planned more like this. But they didn't plan it like that. She just approved the case and did the case. And then, so now she's married to a case. It's become a nightmare that she's married to. And she did it guided. And so she thought, oh, it's all good, but it's not all good. It's not all good because it's like, how are you going to restore the case? I said, well, she asked me, so what am I supposed to do? So I said, that implant needs to be removed and we can replace it with another implant. We'll have to do some bone graft in that area, basically. So that's how you're going to correct it. So it's not easy, right? Now it's become a very difficult procedure now. So always think, maintain the basic, even though you maintain the basic principles, on top of the basic principles, remember from a prosthetic standpoint too. That's key. Prosthetic standpoint is key. So you have to think of it from the crown down. Always think of it from the crown down. So it makes it harder. It makes it a lot more tougher, right? When you think of it, because there's so many variables, and then the bone is not always where you want it to be. It's not always the case. Unfortunately, life doesn't happen in that way. So if you have too wide or too thin, too close, too wide or whatever, you lose papilla in the anterior cases. So, and too deep, too shallow, you lose papilla. So this is where it's so critical. Anterior cases are a lot more difficult because of that. Just because of that reason. It's so much more difficult. It takes more training. And so how do you know when you're going to have papilla, when you're not going to have papilla, right? So the study showed that, from the crest of the ridge here to the bone to where the point is, contact point is, if you have 5 millimeters, about 100%, 99% of the time, you get your papilla back, okay? But so as you get further away, the percentage keeps on decreasing. It keeps on decreasing. So you have to keep that in mind. So it's all about biological width. It's all about maintaining things, So anterior, as I said, anterior implants, if you're transposed on your implant placement just a little bit more buccal or a little bit more lingual, that's going to determine the fate of a screw retain or a cement retain restoration, okay? And so not only that, but just from an aesthetic standpoint too. So it's only a millimeter difference. And we had a little conversation earlier, dentistry is stressful. We deal with 0.5 millimeter, microns, whatever it is. We deal with tiny little whatever. That's probably doesn't mean nothing to anybody else. Lab techs, they know because they want the margins to fit perfectly to whatever the die that's there or whatever the margin that we set on a tooth, and it has to have a perfect fit. So it makes our field or our profession very, very stressful because it's all about accuracy. It's all about whatever, So it's very, very critical that you keep these things in mind. As I said, bone anatomy in the anterior region is completely different. Everybody has so much different variations of their bone anatomy that anterior mandible, anterior maxilla, even the anterior mandible as well too. If you're gonna place implants, I definitely would recommend CBCT before starting anything. I can't re-emphasize the importance of CBCT because the tooth orientation is all different. It's all different. Sometimes it's super buccal. Sometimes it's like super buccal. It's like almost outside the buccal plate buccal. And so it's like it just depends. Everybody has different variations of the teeth basically. And sometimes like past the apex, there's like no bone. This is very classic too, like this. This is super classic phenomenon. It's on the lower jaw too. That happens so much on the lower anterior mandible. Like when you look at the CBCT, it's like you have the tooth and then there's nothing. There's no bone. It's just a very thin ridge. That's it. So it's like it makes it super difficult. So things makes it much more challenging. So CBCT is so important because so you can see the data, so you can get the information, so you can get this knowledge. So this is where I talked a little bit about because you want to be because of the ridge shape on like this. Even if it's like this, we still start the osteotomy more like this, and we're placing the implant kind of like here. So if you want a screw retainer restoration, it's going to be on the lingual. It's always going to be on the lingual. So after the extraction, you place the implant. Your implant should be towards the lingual, okay? And so this is why we create the osteotomy like 3 to 4 millimeters up above the apex, and we start the osteotomy from there, and we go back down to create our space for our fixtures there, basically. So anterior cases, I mean, it requires some more training. So I definitely don't think that it should be your first case. But once you examine the data, you see all the CBCT, then you can consider taking on the case or not. If the root form is straight, whatever, you have plenty of ridge, then it's not a difficult case. I mean, you just have to be mindful of the biological width and all that stuff, basically, and the depth control and all that is very critical. But it's not a difficult case if that's the case. But like that earlier, when you don't have bone like this, or whatnot like this, or something where it's like this, you have to be more cognizant of how the angulation is going to go, then it becomes more challenging. It's not as easy. It's not as easy. So it's more difficult when those cases arise. So, and always be mindful of your angulation. Teeth always have a mesial tilt. Teeth have a natural mesial tilt. And we talked about this last time. This is a very common mistake that happens to beginner implants. So this happens super commonly. You know how often it happens? So during COVID, my mom, she ended up losing 2 teeth, 2 premolars in the bottom. And so she lives in Sacramento. I live in Indiana. So it was during COVID, and she went to one of my friend dentists in Sacramento. I don't know him. I know him from, I don't know his clinical skills. I don't know how well he does things. I don't know how he is a clinical clinician as far as things go, or how good his implant skills are. And she's like, yeah, he told me I can get he'll do the implant here or whatever, and he'll do it kind of cheap or whatever. So I said, why don't you just wait to come to me? I'll take care of it. It's like, nah, I don't want to go without teeth here, and my teeth are bothering me. So she went and got the teeth taken out, 2 of them, number 20 or 21 and number 28, or something was wrong with them. So anyways, so she comes back and she took a PA, right? It's like, son, why does this implant look like this? I know my other implants that you placed don't look like this, and this one looks like this. That's exactly what it looks like. Why does this happen? Why does this happen? So why does this happen? So when you guys are creating the osteotomy, what do we do when we create the osteotomy? We push, we push, we push, we push, we push. So as you push, as you push, as you push, as you push, your angulation starts to deviate. This is what happens. It's just a natural tendency of us because you don't see. You don't see in the mouth. You don't see. So on the right side, number 28 is more straight, but I think it was placed way too buccal too, though. It doesn't look right. But anyways, number 20, the other side, it looks exactly like this. So this is a very common mistake, and I told you this during the surgery. And so this is everybody. I see this everybody, whoever's starting with implant surgeries. I see this so often. I see it so often. So my mom's like, what am I gonna do? She's like, what are you going to do, son? You going to fix it for me? And I have to take it out. And he's like, yeah, later on you got to fix it for me, right? I say, okay, if it bothers you, I'll take it out and fix it. So I got to fix it for some time. So this remember we talked about the positioning, right? So positioning. So if you're just even like, it's supposed to be here, but even if you're off just by a little bit here, you still have a cantilever towards the mesial. This happens very often too, because it's hard to visualize the spacing sometimes. So, it's hard, but you use the tools. There's like the, like the parallel guide kit or whatever, use those tools. It's there. If you use the tools, it helps you. And just know, you got to know how to use the tools too, but if you use the tools, it helps you. It's there to help you. And remember, as I said, teeth have that tilt. It has that natural tilt, so you have to maintain the angulation. So when you're creating the osteotomy here, when you start the osteotomy, if you're centered here, you have to maintain this. You have to keep going down in this manner. As you're going down, you have to keep going down like this. Not like keep pushing, and you go like this. If this came any closer to here, you would damage the root of the next tooth, basically. That happens a lot too. I see that often too, where people do that. So maintain parallelism. This is a very well-placed implant. Like, look, it's very parallel to the tooth in front of it, basically. That's what you want. That's very ideal. So next, soft tissue management. I think this is the most important thing when it comes. So there's so many important things when it comes to dentistry or implant dentistry or whatever, but it all starts with the incision. It all starts with the incision and the flap design. Okay, and then closure. That's the most critical thing. People say they can suture. It's like the same thing. I say people say they can take out teeth. There's a lot of people that can't take out teeth. There's a lot of people that can't take out sutures. I'm sorry. It's like I'm not trying to bash anybody. I'm not trying to put anybody down. But unfortunately, it's real world, and this is people's hands are not all the same. It's just not the same. I guess it's just different. So, but you have to know how to make good incisions. Why good incisions? Because it all starts with an incision. It's like when you make your incision, right, and you don't make a good incision. It's like a rubber band, right? If you half cut the rubber band in pieces and you leave behind little tiny strands, that rubber band's not going to split. And then so when you try and open the flap, things start to tear. You start to tear the tissue. You leave behind hamburger meat. What happens is when you go back to close, it just doesn't heal right. So it's harder to close. It just makes everything should be neat and clean. But if it's not, then it becomes a problem. So incision and flap design is very important. Okay. And so when we make horizontal incisions, you can do a crestal or a subcrestal, we call it, or a slight lingual crestal, and I'll tell you why the difference, okay? And then I talked about a little bit, about the hockey stick buccal incision towards the distal, right? And then when we make any kind of vertical releasing incisions, you want to do it at the line angle, the mesial, that line angle right there, basically. That's where you want to make the vertical releasing incisions, if you're going to do vertical releasing incisions there. So you have what's called the intrasulcular around the tooth here, okay? And then you have the crestal here, basically. So you either a crestal or a subcrestal, basically. I'm not going lingual. You're still on the crest, but you're going more towards the lingual. Why do this? It's a lot of times on the top of the ridge, when patients lose teeth, they lose gums as well too. So gum tissue disappears. They lose keratinized tissue. Keratinized tissue becomes a problem if they don't have it when it comes to implants, because when you have thin gingival tissue around an implant, there's no barrier. You want that thick barrier, but when you don't have it, it becomes a problem. When they brush their teeth around an implant, they'll be like, "Doc, my implant hurts when I brush." It's because they don't have that banding of the keratinized tissue. You need it. It also helps to maintain the biological width around the implant so that you don't get bacteria or debris getting down into the implant, which can cause periimplantitis, perimucoimplantitis, whatever, one or the other, basically. Mucositis, lots of problems, basically. So it's really important. And then so around the tooth, you can do either completely around the tooth and cut the papilla, okay? Or you can do a papillary saving incision where you don't cut the papilla. When to or when not to, basically, right? If the space is too narrow, then you have to cut the tooth because you can't make a tiny little incision and expect everything to place and close, basically. So when you have a big enough space though, and you have healthy gums, your gums are healthy here and here, there's no periodontal issues, why cut the papilla? Why try and induce recession? You know what I mean? So if you have healthy gums, and you have enough space, then you do a papillary saving incision, basically. That's what it's called for. If the space is too narrow, or they have periodontal issues, then I would go all the way to the papilla and cut it open. And I'll show you in one of my video cases. I'm doing SRP on the patient with after the incision, whatever, after the flap, basically, because of perio issues. But anyway, so crestal incision, okay, so. Always the most ideal crestal incision, okay? That's the incision that we always want to make on top of the ridge there, okay? It helps to bring your flap back for closure at the end, and they heal better. Patients heal better all the time with the crestal incision. Less tension. And then papillary saving incision, you want to stay a millimeter away from the tooth there, so. And then also lingual crestal incision is where you're trying to bring more of the keratinized tissue to the buccal, basically. So that's when that's needed, basically. The tissue becomes a little bit thinner towards the lingual, so you have to be careful. So, and you don't want to tear anything as far as things go. So, but you can add more keratinized tissue to the buccal with the healing element afterwards. So, and the vertical releasing incisions always at the line angle. Okay, always at the line, not here. Okay, not here or here, basically. That's where you want it. So that's where you make your vertical releasing incisions for better blood supply. Always have a wide base too, because it's all about blood supply on your flap. So if you don't have good blood supply, you don't heal right. So the incision should be very deliberate. When I say deliberate, you have to make a very clean cut. So when you put that blade into the tissue, right? You want to make sure that you hit the bone and you're scoring the bone type of incision. Okay, your blade will dull out after like 1 or 2 cuts, basically, because they're very sharp, number one. And then I want you to, when you make a cut, I want you to be very deliberate and actually cut all the way down, because I don't want you to leave behind any fibers. Because when you leave behind fibers, and so if you make your cut and you're like very gentle, right? And you don't cut all the way down and you start scraping and then you come all the way through. And so you have all these fibers below that are still attached, right? And you go to lay the flap, and so you don't have a full thickness flap, number one. You have a partial thickness flap. So now you're starting to get you're starting to get tear, hamburger meat, whatever, which is not good. So it all starts with the incision. This is where incision is so important, basically. And then there's the intrasulcular incision, basically using like a 15 or 12, usually a 15 blade, basically, if you're gonna do that. And then, so you always want to make sure that, when you lay the flap, you maintain a wide base. You want to maintain good blood flow. You don't want to have any tear, basically. You want a clean cut, clean flap, basically. Because when you have tears, when you go to close anybody up later on, it's hard to get primary closure. It's very, very hard to get primary closure. And primary closure is key to getting good healing. Body heals pretty well, but if you help it, it makes a difference. You got to help it to make a difference. And this is one of the ways to alleviate that or prevent that. There's different types of flaps. There's like the semilunar flap. There's the trapezoid flap. There's a triangular flap. And there's also the envelope flap. I like the envelope flap because you don't have to release, there's no vertical leg. But the problem is the tissue becomes tight, right? And so because the tissue is tight, you can tear more if you try and keep going, you know what I mean? When you try and pull it out or whatever. But so you have to be careful with the envelope flap. But as I said, if the more you do like this, it's more traumatic. So there's more pain associated with the procedure. The less you do, there's less pain. So this is one of the benefits of an envelope flap, but it's more technique sensitive as far as things go. And then when you guys make your cut, you should hold your scalpel handle in a writing pen grip, okay? And you want to cut always towards you, not away from you, okay? You don't want to use the edge of the blade. You're using this part of the blade to cut, not the tip, not the very tip. Okay? And then you always want to cut towards you, not away from you, because you can slip if you try and cut away from you. So you're always holding and then you're cutting towards you, okay? You should have a good fulcrum base as you're cutting. And then when you guys go to suture or whatever, if you're holding the needle, you never want to hold the needle at the very tip like this, because you can damage this area where the needle and the suture is actually connected to. So you always want to be a little bit away from the swatch of the needle, we call it, okay? And then when we make our penetrations, the bites that we call it, right? You want to be at right angles. Your needle should be driving into the tissue at right angles, and not so that you're grabbing enough tissue as you're going in. And then you always want to follow the curvature. We usually use a reverse curve, C-shaped curve needle, or whatever, and so you just want to follow the curvature of the needle there, basically. And then you should be about 2 millimeters away from your incision, basically, or 2 to 3 millimeters away from your incision. Suturing is all about vectors, So you want to grab the tissue, like if you grab it here, you always want to grab it here too. You don't want to be here, and then you don't want to be all the way out here. That's not good. That's not good. So you always want to maintain that if you can, okay? And then when you have attached gingiva, if you're having a vertical releasing flap, you want to go from the free side to the attached side. The reason why is if you go from here, you tend to tear this basically as your needle's driving. But it's not always the case. Sometimes you can actually, if the space is tight, you might have to go from the attached side and be real careful. I don't suggest using needle holders either, because remember, when you try and unclick the needle as it's held, when you're going to the attached side, you tend to tear the tissue, because it's like you're trying to manipulate that needle holder to unclick it, and then so Castro Viejos are very good for those areas. But yeah, this is very hard. This is very hard. If you've done this before, you know what I'm talking about. because tissue, especially on patients that have thin tissue or anything like that, this tissue is frail and things will tear, and you keep tearing the tissue, and then this is where difficulty arises, basically. And then you should start from thinner tissue to thicker tissue when you guys make your, as far as suturing goes, not from thick to thin, the other way around. And you always want to go from shallow to high, not from the other way around, because it just helps to bring it up, basically, to better closure. And the depth, it should be greater than the distance of the incision, basically. Okay, so it should be deep enough. That's what it means. Okay, but it just depends on the flap as far as the flap goes. So sometimes if it's a flap, you're not concerned. That's if you're actually going in like not really a flap of tissue, but. And then you don't want your knots or tight to be too tight where you're blanching the tissue. Like you don't want to be super tight, so because what happens is you get necrosis. If you blanch the tissue, you get necrosis. That's what happens basically if it's too tight. So you should be like, there's an ideal tightness, we call it. You don't want to be loose either, where it's flappy either, but you want to be somewhat pretty decently tight that it's not blanching the tissue. So. And then the knot should not be on top of the incision line. You should kind of move it away from the incision line because that helps promote healing, okay? And then our inter suture distance should be about 3 to 4 millimeters, if you're doing interrupted sutures or whatnot there, basically. Simple interrupted sutures. So how to make a simple interrupted suture, okay? So we take a bite, and we bring it over, take another bite, right? And it's pretty simple, right? And then you tie, right? So you tie that knot, right? And you keep doing the same thing. Same thing, same thing. It's like multiple sutures, right? So my daughter, right after Thanksgiving, she's 14. She was down in the basement. So I live in Indy, so we have a basement. Here, I know you guys don't have basements here, but yeah, so we have a basement. So I have a gym in my basement. So this is one of the luxuries of living in Indiana. So we have a big, it's like our houses are bigger because it's cheaper. And I have a gym. I'm not trying to brag, but I'm just saying I have a gym. So my daughter went downstairs. She said she's going to exercise. So she got all dressed up. She was down exercising. I guess she was using the ab roller thing, whatever. And I have a gym where it's matted, but she was on the hardwood floor area. I guess she was doing that, and she slipped, and she fell, and she cut her chin open, like on the bottom here. So we had to go to the ER. I mean, technically, I guess I could have sutured it up, but anyway, so I haven't gotten the bill yet, so it's going to be probably a couple grand for that, even with insurance. I don't know. But anyway, so they placed like 4 interrupted sutures, basically, on her, So they use just plain gut sutures, I think. She used plain gut sutures, and so 4 interrupted sutures like this. So it's pretty straightforward. This is what we do day in, day out, basically. Interrupted sutures, so. And then there's the horizontal mattress sutures. This is very important for like when you do GBRs. Horizontal mattress sutures it's effective. What it does is it helps to kind of put less tension on top of the ridge when you create the suture, basically. So remember, we talked about like having tension-free closure, we say all the time, but there's no such thing as tension-free closure because there has to be tension somewhere. Because when you open things up, you add implant, bone, all this stuff, things are going to get loose, right? I mean, it's going to be tight because you're trying to close this back up again, right? And even though you release the tissue and you close this up, it's going to be tight, right? But we're trying to relieve the tension right here at the very top, right? And so when you create this horizontal mattress suture, the tension comes to below the incision line, right? So more of the tension is here. So when you put the interrupted sutures on top, there's less tension on the very top, where the tissue is very, very frail, I guess you could say. It's more delicate. Now, I'll show you how this is done. But this also is a good suturing technique to stabilize your membrane when you do GBRs. And I'll show you that too. But anyways, this is a very good suturing technique. So how to make a horizontal mattress suture, okay? So normally, like I would bite further away, okay? But this is just a diagram. So normally we bite further away because you want to be below this area. You don't want to be near the incision line. You want to be below, further below, like maybe 4 or 5 millimeters below, okay? So I would take a bite here, come out, same thing, bite over here, basically come out, okay? And you come across horizontally, right? Take the same thing, you take the bite 4 or 5 millimeters across, come over the ridge, and from the inside out again, okay? Same thing, 4 or 5 millimeters outside, you come out through. So it's horizontal here and here, basically, that's what it means. So the strings are going above the ridge. So it's from either the buccal or lingual, right? You're coming here, out above the ridge, down out to the flap, basically, right? And you're coming horizontally, either direction, whatever, right? And then you're coming from buccal to lingual over the ridge, from inside the flap, out towards the lingual, whatever, buccal, whatever, right? And then we're making our tie. That's how we're making a tie. So same thing, that's how that picture is showing, right? That should kind of give you a pretty clear picture of what I'm talking about, right? And then you tie. So when you tie, this is what happens. We call it So when you tie, this is what happens. It starts to do this, basically. Tissue comes together like this. Then the vertical mattress sutures is exactly the same thing, but the direction is in the vertical direction here. Instead of horizontal direction, it's in the vertical direction. Okay? So there's vertical sutures and there's horizontal sutures. So 물병 하나 주겠어요? Are we ready? Go? Good. Okay, welcome back. I hope you guys had a good lunch. We did here. I don't know about you guys at home or wherever you guys are at. So back to our vertical mattress sutures, okay? It's pretty much the same as our, what did I do with my pointer? Did I leave it on the table? So back to our vertical mattress sutures. It's pretty much the same as our horizontal mattress sutures, but the vectors are in the vertical direction instead of in the horizontal direction. So it's almost similar, very similar to the horizontal mattress sutures. They are mainly used for, like, if you're doing connective tissue graft in the palate, we take those usually for those type of vectors. And so that's what they're used for. And then figure 8 sutures, these are great for extraction sockets. I use this often, very often after extractions. They help to create nice closure after an extraction site. So it's very simple, horizontal. So you do the same bite and pass through like a simple interrupt the sutures, and then but you come across again to like the mesial distal of the extraction socket, let's just say, and then you go through again once again like an interrupt the suture, and then you just create a tie when you're done. So it creates that X on top. So it's very simple. It's not very complicated at all. But these are great. These are great for post extraction, like on a premolar site. They're really perfect. So sometimes on a molar site after an extraction, if I'm doing a bone graft, I use a figure 8 within a figure 8, and then I tie, basically. So the 2 wide figure 8s, because the span is pretty big, right? So if you put an X and just put an X, it's like too big, it's too wide. So I go figure 8 to the out, like mesial distal or whatever of the tooth, like in between the distal of the tooth and the mesial of this tooth, whatever. And then I do another figure 8 in the middle of it too, and then I tie. So it's like a figure 8 and figure 8 within a figure 8, basically. So they're very useful. And then crisscross sutures is almost like a figure 8, but the directions are a little bit different. Okay, the way how you go through. So from here, like here, for instance, you're doing like a, it's not a horizontal mattress, but you're going in the horizontal direction. You're going in the horizontal direction, and then you come through on the opposite side of the incision, and you do the horizontal vector as well too. Once again, and then you just create your tie. So the X actually gets underneath the flap, so you don't see the X. Oh, wait. Oh, this one you see the X. I'm sorry. This is a hidden X. Okay. So this one's a little different. So it's almost the same, where the X is hidden underneath the flap. So this helps to prevent the gathering of the keratinized tissue. If you're trying to help keratinized tissue grow more, this is one way to do it. So this one you actually cross from here horizontally, but you come across in a diagonal fashion to the other side of the incision, the flap. And then you go back to here, across, and then go diagonally again to the other side. And then so you get the hidden X underneath. So the X becomes underneath the flap. And then so this is like the horizontal and a mattress suture together. So internal mattress, either an internal vertical mattress or internal horizontal mattress. These are great for like GBRs. We use these all the time for GBRs. This is the best because what happens is when you create that internal mattress suture, the flap looks like this. It comes together down here at the base. And so you get what's called a praying hand, we call it. So the flap looks like this. So this is tension free up here. The tension gets down here on the base. And so, and then you put interrupters on top. So these are great. And this is also great for like fixating the membrane. So we start with like this is a vertical internal mattress in this manner here, in this picture. So you start with the vertical mattress basically to stabilize. And then this is going within the tissue here. But you can come all the way out. So we use it within the tissue. If you have a membrane, you're trying to stabilize the membrane, I use the interperiosteum basically when I'm doing this type of suture technique basically. But so you put an internal mattress suture, and so your tissue gets tight. Like when you tie it, it becomes like this basically, and then you put an interrupter on top. And then continuous sutures are really good too. I don't use regular continuous sutures. I use continuous interlocking sutures, and the reason why is the vectors of this kind of is more diagonal to the cut, to the incision, but when you have continuous locking, it kind of straightens the vectors out. It's more straight. I use these all the time for lower 17 or 32, or even just lower extractions, whatever. I use this all the time. I think it's a fantastic way to get primary closure on lower areas, basically, because tissue has give, the flap has give, basically, and so when you use this, it creates a nice tight seal. It creates a pretty decent seal in the back areas. So or even if we're doing like a full mouth extraction case or whatever, I do continuous interlocking sutures for closure. These are really, really good. And then so this is what I was talking to you about earlier about how to stabilize the membrane, basically. So you place the implant, you place some bone graft, you place the membrane, you did some GBR, right? And then so you can place a mattress suture, you can place a horizontal mattress suture. You can do it where it's crisscross, or you can do it, whatever direction. The way so you're doing a horizontal mattress suture where you come like from here, come across. So you're biting within the tissue here, basically, coming across and then coming out, and then you're tying, basically. That's all you're doing. You usually on the uppers, you want to start on the palate because the tissue's thick. The palate tissue is very thick, So you start on the palate so that you can tighten that sucker up pretty good. And what it does is this membrane, it kind of moves around everywhere right now, right? But once this is on there, the membrane gets tacked in. It stays still, basically. And then you can put another horizontal mattress suture where you come through here, and then get the flap closed. And that way the flap becomes nice tight again, and then you can do interlocking or whatever sutures you want on top there to close that up. So these are really great for GBR cases. And then to tack, it's like a tacking suture. So if you pull on the cheek and the flap or whatever the incision, the surgical site moves around a lot, this is contingent upon the fact that you did like a split thickness graft. Like this is more for connective tissue graft and stuff like that. So that because it's like the periosteum is still intact, so you drive the needle through the periosteum to attach the tissue so that it doesn't move on you because stability is very important after grafting procedures. Because if you pull the cheek and you can move that, then it'll fail. The graft procedure will fail. So this is to help to stabilize the tissue from moving if you pull on it or anything like that. And then this is like if you lay a flap and you don't want it in the way, and you're putting a guide or whatever, you can just put an interrupted suture to help retract the tissue for you, so you don't have to keep retracting it. So that you can use like silk for this type of, because you're just gonna cut and throw it away, But yeah, but like regular, so when you close up, you don't really want to be using silk for regular like closures like these or whatever, because silk tends to build up a lot of plaque. And so that's the reason why I don't like silk. So Vicryl sutures or like PTFE sutures, those are better. So how to make a knot? Okay, so we call it surgeon's knot. This is the most classic knot. I use this day in, day out. So it's a 2-turn clockwise direction, 1-turn counterclockwise direction, and then 1-turn clockwise direction, basically. So in order for you to have a nice tight, like when you first make your knot, your line here should line up, basically. That should try to get it lined up, not crisscross if you can, because that way when you pull with the hemostat, whatever your needle driver is, right? When you pull on it and you have the tail, if you let go of the tail shouldn't follow. It should hold. If you pull really hard, the tail will follow, but when you hold on it, the tail should stay. That way when you make your counterclockwise turn and you grab the other end of the tail and you tie it stays tight, basically. Versus if you pull on it and the tail's following you, then it's not going to hold, and your flap closure is going to be like loose, basically. So that's a simple how to make a surgeon's knot, and then you have a square knot, which is just 1 turn clockwise, 1 turn counterclockwise, 1 turn clockwise, basically. So one of the main differences is just 2 1 1 versus 1 1 1, basically. That's the only difference. So square knot. And then when you go to remove, just cut. I mean, this is pretty simple, basic. I mean, I don't think this requires any kind of explanation about removing sutures. Just make sure you cut the knot. You know what I mean? You cut the knot and then you pull the other side where the knot is not present. So, suturing is just to hold the tissue for a few days. That's it, mainly. So it's not really to like keep everything super tightly closed, and then you're relying on the body's healing process to attach, to reattach. So after any kind of closure of any sort, I always say put pressure on the wound, because remember, you've laid this flap, you relaid the flap, and so there's what's called dead space. Even though you put them back together, there's what's called dead space, like it's air space, basically. So you want to try and get rid of it. So take a piece of wet gauze or gauze, just put it there and put pressure on there. Just put it all down, tack it all down so that you get nice. And also, if you did any kind of GBR or bone graft procedures, you want to make sure you put pressure on the bone to make sure that the bone actually is nicely condensed to the actual bone, whatever that's there. So there's no voids or anything like that. So this is more about surgical cases, okay? So I'm going to talk about a little bit of bone grafting first, and then a couple of implant surgery. So as I said earlier, like, you know, keys to getting good implants or implant placements or anything like that is getting good at extractions and being atraumatic with your extractions too. You don't want to create a lot of trauma. So if you see these type of cases day in, day out in your practice, right? In the molar region, I prefer not to place immediate implants. And as I said, your osteotomy, when you create the osteotomy for the drill, it always wants to follow the path of least resistance. And if you have extraction sockets, it's going to follow to the path of least resistance, which is the socket, the extraction socket, basically. But your implant's never going to want to go, it's not, the ideal positioning of that implant's not in the socket. It's like usually at the center where the furcation is, you know, on a molar area or whatever. But once, even though you create the osteotomy perfectly in the center of furcation, once the teeth are gone, you still have all these empty holes, and it's going to want to drift, basically. So that's why it's not ideal to try and place your implants. And also, it's hard to predict exact bone level of where it's going to be after it's healed. So it's better to just extract it and graft it. I prefer that procedure day in, day out. On our premolar side, you can do immediate extraction. I do routine immediate extraction and placement because it's pretty predictable. Even though you have buccolingual, whatever, it's pretty predictable as far as, you know, the healing there goes. And there's less, you know, it's just buccolingually where it's going to go, not really mesiodistally, you know. But with molar areas, there's too many variables. And so I think, and from a restorative standpoint, I think it turns out, I noticed that the results are much better when I do like extraction bone graft versus immediate extraction placement, I think. And it's not about being better or better, but, you know, oh, like, you know, I'm more experienced clinician than you are and I did more implants that I can do this better. It's not really that. It's just, I think the results are much better if you just do the graft procedure first, I think. Anyway, so I love using like the Orban knife. That's one of my things. I mean, everybody has their own preferences of what they use. So I go around the tissue to separate the tissue and the tooth from the tooth with it. And so, so I go around and then I'll split the tooth. Whatever you need to do to take your tooth out, you know, atraumatically as possible. Because if you notice, I haven't laid a flap. I haven't really laid a flap. I'm just going around the tooth and just kind of separating the bone and the gums. And then I split the tooth. Like whatever the tooth needs to be split in whatever direction, if it's buccolingual, whatever it needs to be split to get out, I try and get it out atraumatically as possible. And then so you see the socket, it's just the extraction socket. So once the tooth is out, I make sure that there's no granulation tissue left inside the socket. I take a curette, and we talked about it, you know, 2 days ago or whatever, but you want to make sure that you scrape that bone. You want to hear that solid scrape sound on the bone. You don't want there any tissue there at the apex of where the root is or around where mesiodistal or whatever it is. You know, you don't want to leave behind any granulation tissue because if you do and you put graft in there, it's going to fail. It's not going to work. It's not gonna work. So you have to make sure you get rid of the granulation tissue. And to tell if you got it all out, what you do is you take some sterile water and irrigate, suction it up, and take a look. You'll see it should be clean bone, basically, not tissue. If you see tissue, take the curette again, scrape more, and scrape more. I keep saying scrape, scrape, scrape. You have to scrape, 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 a lot. And then so I take cortical bone. It's a small particle cortical bone. That's why it's just my preference. I use that, but you can use cortical cancellous bone. I don't like bovine bone because it takes a long time. It doesn't disappear. It just stays there. And I like to see natural bone turnover over time. So I like cortical bone. So anyway, so I use cortical bone. You can mix it with, like, I sometimes mix it with clindamycin. I sometimes mix it with metronidazole. I just mix it with sterile water. That's another thing that I mix it with. Sometimes I take blood. I use PRP, mix it with PRP, whatever, you know, to make sticky bone, whatever it is that I need. And then we just pack. Pack. I get nice condensation. I just use a curette to pack too. I just use that curette to pack. I use that curette to clean out, and I use the curette to pack. So I'm trying to keep it simple. I don't want to have a whole lot of armamentarium that you have to clean up and sterilize. You know, I want my instrument pack to be simple, basically. And then so it's nicely packed. I pack to the level of the crest. Okay, that's where you don't want to overpack. You don't want to underpack. You don't want bone like on top of the gums. You don't want too much gum above the area, because what happens is when they heal, it disrupts the healing, and then you get these bone particles that are embedded in the gums afterwards, if you have too much, okay? So you want to just pack to like the buccal plate, basically. That's where you want to pack to. And then I take a piece of gel foam, okay? Gel foam goes away. It disappears after a week or like actually less than a week, actually. It'll go away. But it's just to act as a little barrier, basically. That's all it is, okay? And then I take Vicro sutures, and then I'll suture. The Vicro sutures, PJ sutures. This is kind of a big one. This one that I used there on that day. So I use that. And then I do a figure eight within a figure eight, basically. So you'll notice that it's like figure eight, and then I put another figure eight. So you'll see, like, see, I have the main figure 8 starts from here to here, and then it comes from here to here to here to here, basically. So it's like 2 figure 8s within a figure 8, basically. It's like I just do it out. So you can think of an outer figure 8 and an inner figure 8. That's all I do, and then I tie. That's all I do. And then a week later, I see him back for a post-op, and that's what it looks like. You're not going to get primary closure because the tooth is big. It's not possible to get primary closure within this, okay? But this is like a week later, and then 2 weeks later, 3 weeks later, gums heal over, and then you get nice keratinized tissue back up again on top of there again. So that's what I want. That's what you expect. Why do I use a membrane? Because number one, it costs money. It's a lot more expensive, right? And so if you keep adding all these fees to the patients are like, I'm not going to do that. It's like too much. Is it necessary? I mean, I don't think it's necessary. I've done this many, many times, and it still works very well. So I mean, I know some doctors are like, oh, we put membrane on top, you have to get closure, And then later on, you have to, like some patients use the non-resorbable membrane, so you have to remove the membrane. So why go through all that? Why go through all that hassle? It's like, this works. It's cheap. Gel foam's cheap. You can whatever. A box is like $60. I don't know, whatever it is. But. So now, new technique, right? It's called Dermabond. It's like a bond. It's glue, cyanoacrylate. It's just glue for the mouth, basically, okay? So same thing, we pack bone. I put gel foam, but I wait. I wait for the bone, the gel foam to get soaked with blood. You have to wait for it to get soaked with blood. You can't put it on dry, okay? And then so you notice the cotton roll back here, because you don't want it to drip or flow, okay? So I take this Dermabond, it's like a bond, okay? I use this, and then I have a little carrier, right? And I put drops in it. I have a wet cotton pellet on hand, and you dab it on top with the wet cotton pellet. And so once it's on there, right, it solidifies immediately. And this is what it becomes. That's like immediate. Like that's how hard it becomes. So it creates a barrier, a seal. Like it's temporary. So but you got to tell the patients you don't want to get too much on there because it's going to flow everywhere. So that's the reason why I have the cotton pellet back there, okay? And I keep cotton in there to make sure that it doesn't go everywhere. And you just tell the patient you're going to notice these like plastic things kind of chipping off, kind of whatever. And they sell pipettes, that you can carry. So you just soak it up in it's like a little bobber thing at the tip. It's a pipette, right? I get it from Shine, but you can get it from Shine. So you just draw a little bit up and you just have it on hand right there. And then you just put drops. I just put little drops, incremental drops, and then I just take the wet cotton pellet and just wet it basically. And then, so after like a week later or whatever, to create a seal on top. So this is granulation tissue that you see here after the extraction. So I want all that out. I don't want to leave any of that in there. So we scrape and scrape and scrape to remove everything out and make sure it's nice and clean, basically. None of that stuff is in there, basically. Then we remove all that granulation gunk. We get all that out. I drew some blood, make some PRP. Yeah. And then so got the slugs, whatever. Mixed with bone. I didn't make sticky bone at the time. I don't know why. I think it was just, I don't know. I was like going back and forth. I'm like, should I document this or not document this or whatever? And so, anyways, I made the PRP. So I used the PRP and I put it in the membrane, and then I sutured this up. And the way how I sutured this is I use a modified figure 8, basically. So I actually grab it from here. So I want to grab the membrane, right? And then I grab the mesial tissue, and then I'll go loop around back. So it's like, normally when you make a figure 8, I will go from here to here, right? And then come here and go here to here and tie, basically, right? But I'm not doing that. Instead, I'm going here to here, and then I come here to here, and I'll come here to here, and here to here, and then I'll tie, basically. So it's like a little bit of a modified figure 8 that I use. So what it does is it tacks the membrane into the socket, and it creates a seal. So that's what, and then I also I took one more in the middle, I think, to stabilize the membrane. So that's what I'm doing to stabilize the membrane there. And the membrane will disappear in less than a week. It'll go away too, but at least it creates you get pretty, primary closure within the first day or whatever. Another option is you can take a tissue from the distal tuberosity area, and you can cut it out. You can size it and measure it, cut out, like fillet some tissue out and just put it in there as a plug to seal it up too. That's another option, but that's another site that the patient has soreness, and so they're not happy with this. So I try not to do that if I can. So this is I did bone graft. I took the tooth out. We did bone graft, and I'm ready to place the implant. So this is the case that I was talking to you about earlier. So this is straight, but this has a tilt, right? Because the patient's been missing this tooth for a bit, right? So it's or this is the way how he was, right? So you have to find a kind of a compromised balance, right? You don't want to place your implant like this, because then you have like a mesial tilt here, basically. So you have to it's more ideal to place it more like this, I guess. And so this, the patient has a wide bridge, actually. The patient has a nice wide bridge, and this is what it looks like, the tissue. So you have plenty of keratinized tissue, And so in these type of cases, I want to, and I talked a little bit about being atraumatic with my surgery. So I just did a punch. So this is betadine. So I got the patient numb, and then I scrubbed the site with betadine, basically. I do this pretty routinely for most of my cases, unless they're allergic to iodine or shellfish. Then I don't use this if they have any kind of allergies like that. But I just do betadine scrub. I create a punch. I perfectly put the tissue right there, or I size wherever it needs to be, right? And then I create the punch. And so I remove the core tissue. So I'm not laying a flap. So this is very traumatic, basically. And the patient has enough of a ridge, so I'm not really concerned, as far as. So then I start my osteotomy. So I use the initial drill, the next drill, and then I place the parallel pin, and I have them bite. I check to make sure that I like the direction, the functional, the mesial-distal angulation, the wherever, the buccal-lingual angulation, all that stuff. And if it's off, I correct with my next drill. I make sure I try and correct what I'm off, okay? So I'm taking these precautionary steps just to check. But it doesn't take me very long, so I'm checking. So remember, I told you I don't want this to be like this. I want this to be more up and down, right? So that's why this looks like that. And then I have them bite down to make sure that it looks, it's happy with the functional cusp. And then I proceed on next drill, whatever, so forth, so on. And then I place the implant. So the implant's starting to go in. And then this is a big implant. This is like a 6.0 by 10, I think, or something. So I'm hand driving it in, and then I check with the curette. I go around to see if I'm to the depth, because you can't see it, right? Because I don't have a flap, right? So it's hard to see. So you feel for the buccal plate, and you feel to see where your crest is. And so I take a curette and I check. That's how I'm checking. And then I place the healing abutment on top. And then, sorry, I don't have the post-op pictures anyway. So this one was, I think we're taking this one out, and then we're placing one back there for bridge, implant bridge. I think that's what this was. So I make a lingual crystallized incision here, like you see the buccal hockey stick, and then it's not on the crest, it's more lingual, right? And the reason why is because if you look here, there's not much keratinized tissue. There's very, very light. And then you can see where the mucogingival junction is, like it's pretty high up, right? So you want to have that band, right? So I'm going to utilize the implant and the healing element to push that out, basically. That's what I want. So I create that incision on purpose, okay? And then the tooth is out. I took number 20 out, basically. And I did an immediate placement. This is a one-day implant, basically, that I placed on there. I drive it down, and the osteotomy has already been created. And so there's a little bit of a jumping distance to the buccal that you can see. So I packed that with bone. I just put some bone graft material in there. And that's a cover screw on there right now, but I'm going to change that to a healing element, like immediately, because I got good stability with the implant. So I like to create a seal with the healing element if I can. So it's important that you create nice stability with your implant. So once you create because now the tissue has to grow over, right? But if you can cover it up with the healing element, then it creates a better seal, right? So there's less room for the tissue to grow, less space for the tissue to grow into, basically. So it makes it better healing overall. And then the back. So I like to place the front one first. Whatever one that I'm going to place, I like to place it first. Why? Because so I can guide myself with it. So I actually placed like an impression coping on here. Something on there, basically. I just try and place something on there so I can use that as a guide for me to guide my angulation of the distal implant that I'm placing. That's what I'm using, basically. So I use that to create my osteotomy. So I have that on there on purpose. So it just helps me guide my orientation of what angle I need to go into. Like either buccal lingual or whatever it is, right? And then so this is another one-day implant that's going in. And then I hand drive it down into the depth. And these are the healing elements that I put on there, basically. I placed a little bone graft on there because it was a little thin in some of the areas. And there was some bone left from earlier that I mixed. So I place some bone graft and then I suture them up. But her tissue is kind of thin, but this is what it looks like. I get closure, but it's still a little bit over the healing element, right? Not a big deal, but this is what it looks like 2 weeks later. Look at the tissue. You see the big, thick keratinized tissue that's building up? That's good. That's what I want. That's the reason why I did the case like that. And then so this healing element is buried underneath the gums, right? So I switch that out. I take it out. I place a taller one. So because it's taller, you have a little bit of a gap on the lingual right now. But as she heals, it's going to tighten back up. And she's already restored, actually. So I don't think I added the pictures on here. But that's one of the reasons why I like that lingual crystallized incision. It's still in the crest, but it's more lingual, so you can bring that keratinized tissue to the buccal and add to the tissue. So that's what the old healing element is. It was slightly not down, actually. But anyway, so this is what it looks like, the new one. So it's much taller. So, and then so before to after, you see the difference in tissue, and you see the new mucogingival junction forming. It's lower. It's getting lower, right? That's what you want. You want the vestibular depth to be deeper. And that's what happens when they lose teeth. They lose the vestibular depth as well, too. That's part of the thing that goes with it. And so this helps to get that back. So this is like number 4. I think it's number 4, yeah. A video of me taking like immediate placement, just the placement number 4. So this is me doing Betadine. This is my routine. So patient's numb, I think already. I think I already numbed the patient. So it's like live. So it's just doing Betadine scrub. And then she has tartar back here. Like this, just like a whole bunch of tartar underneath the gums there. She needs SRP, but she hasn't been coming in to do it. But she wanted the implant done, so I said, okay. So I'm taking peritome and I'm scraping off the tartar. I'm trying to scrape out the tartar, but it's still there. It's not coming off, right? Because I'm still deciding on the fate of if I'm gonna lay a flap or not, right? Because I would just, because she has a pretty nice wide ridge, and so I could have done this case punch. Like I do a lot of my cases punch instead of laying a flap because, as I said, I like to create less trauma for the patients, and patients like it when there's less trauma because they have less pain. They come back and get more done. So, but in this case, because of I couldn't scrape the tartar off, so I decided to lay a flap. Yeah, I raised a flap, so I'm making an incision. And even though she has plenty of keratinized tissue, I'm still directing my incision slightly lingual to the crest, just in case I need to gain any kind of keratinized tissue on the buccal, basically. So, just very minor. It's not very major, basically. But she's got plenty of good tissue. And the way how I use my periosteal elevator, you'll see here, basically. I love to use the tooth as a fulcrum, okay? Because it doesn't slip. The thing is, when tissue tears, it's because when your instrument slips, that's when it tears too. So I put my periosteal elevator in there, and I'll use the tooth here against this here, and then I'm just elevating off the tooth kind of to lift the tissue up, basically. That's what I'm doing. So I'm just utilizing the tooth. So I get a little separation, and then once it's separated, I'll use the tooth. See, I'm using the back molar to elevate off the molar. And so it just comes right out. There's no slippage, and the tissue comes out clean. It's a clean removal, basically. So I create a little bit of a lingual, and the reason why is because there's all this tartar here. I don't know if you can see it on the video here very well, but there's quite a bit of tartar on that mesial of that tooth there, number 3. So you'll see me taking, see, after this, I guess, you'll see me taking the periosteal elevator. See, I'm scraping the tartar off that tooth right now. That's what I'm doing. I don't know if this is like very visible on the video or not, but that's what I'm doing. I'm scraping that tartar off the tooth right now. That's what I'm doing. I think I mentioned it's free SRP for the patient, whatever. So. Almost kind of doing the same thing on the other end too, but. And then so, next one I think is continuing. So, then I just do my osteotomies basically. So I'm going to start my osteotomy and see where. I think I already did the first initial pilot drill, and then so this is the next drill, 2.2 drill, whatever, the twist drill, and I go down to the depth that I want. And you'll see me put the parallel pin in, right? And then I check the bite. So I just have them, I'm looking overall. I don't know if you can if the video capture everything that you can see at all, but I tried to see if I'm happy with the mesial distal angulation, the buccal lingual angulation, if it's pointing towards the functional cusp or not, you know? So I'm checking all those kind of things with it. And whatever, if I don't like, I'm going to the next drill, but I'm just correcting with the next drill when I'm doing it, basically. Most single placement cases don't take very long to do. Once you've done a lot, you tend to move pretty quickly. So I'm just kind of next drill, like going step by step to next drill to the depth, basically. And you notice, I don't try and keep it like this one. It feels like it's in there for a bit, but I don't usually keep it in there for very long. It's just up and down, in and out, basically. So now I think I flipped the parallel pin again just to check again one more time. If you look, yeah, see, I have the patient bite down, and they usually can't bite all the way down because it's too tall, but it gives you a reference, you know, it's just so that you can see. It's not so that you can have a clear reference of biting all the way down, but it gives you a reference of what you can see, basically, so. So if you look just a bit, I don't want to pause this because I don't want it to crash, but I'm right in the central, see, I'm right in the, like central fossa, right? Central fossa, that's where you want to be. That's the ideal location. I'm thinking of it from a crown down perspective. I just want the tooth to be there. I want my screw hole to be, I'm thinking, where's going to be my screw hole, right? So that's my screw hole. And the angulation needs to be here to hit the buccal inclination of that buccal cusp of number, whatever the opposing tooth it is, you know? So I go to the next drill and just go down to depth, whatever, I think it's a 4x10, whatever that I'm placing on here. So I go to the 10 millimeter depth with my next drill. And I believe we'll just place pretty soon here. And if you notice, I haven't laid a vertical releasing flap. It's just an envelope, like a little mini flap, yeah. And the reason why I laid this flap was, I guess this, number one is to show a video for you guys. Number two was just to clean the tartar off, too. That's all, basically, so. And then, yeah, so this is the next one more drill, yeah, I guess. So. Maybe it was a 4.5. I don't remember what the size was. Maybe it's a 4. I don't remember. Yeah, change my settings, and then so it's on the implant. Make sure it's on the slow setting, never on the fast setting when you go to place your implant, right? You always slow it down. You slow it down really well. Then grab the implant. Yeah, so it's a 4x10. That was the size. You notice the foil, it's a sterilized foil on the handpiece. That's what I was talking to you about like 2 days ago. That's what I do. Because you can't sterilize the actual motor part of the handpiece, you sterilize the handpiece. So that part we try to keep it sterile by wrapping sterilized foil around it to keep it sterile. I'm just trying to lock the implant into the driver. This is like an empty active, I believe, 4x10 one-day implant that I placed. And make sure it's going in slow and just drive it all the way down. Remember, you can still change your angulation as you're placing. So I'm keeping that. I'm constantly looking at that. I'm still checking. I'm still making sure that I'm happy with the positioning and the placement and the angulation overall. So. And I hand drive the rest of it in, basically. I guess there's something I didn't like. I don't remember. Oh, I think there was a little bit of tissue on the something, or there was something on there, some kind of debris or something on there. I wanted to clean out or something or another. I think that's what it was. So I'm just going back in to clean something out. I think because I'm wearing loops, I can see. I think there was something on there that I saw that's like kind of not shouldn't be there. So I'm just trying to clean it up a little. Or it was too tight. So actually, I'm enlarging the osteotomy. Okay, so I'm enlarging the osteotomy here. It wouldn't drive all the way down. It was too tight. It was going in tight, and it was like too tight. It wasn't driving all the way down. So I'm going back to implant driver setting. So I enlarged the osteotomy to one size bigger, basically. I went up to the next drill. That's what happened. Oh, yeah, now, see, I'm just irrigating because there was some debris, I think, on the implant. So I'm just irrigating. That's what I'm talking about, yeah. So I'm just irrigating the implant, so. Yeah, there's like a little tissue debris. I'm just cleaning that off. Like I try to irrigate it off. I try not to touch the implant if I can. I don't definitely touch it with my glove. I never touch it with my glove. And then, so if I'm ever touching it, I use like whatever instruments that I have. So I'll hand drive it in real quick, and then once it gets tight enough, I'll just pop it off and just drive it in with the motor. And if I can't get all the way down, I'll hand drive the rest of it way down. But if it feels super tight, then I'll take it out and enlarge the hole just a little bit bigger. So yeah, that's just me driving it down. And it's still a little bit above the crest, so I'm going to hand drive the rest of it in, basically. I'm just laying the flap back so I can see if I'm to the crest or wherever, as far as the crest goes. So. I think I saw some kind of debris there, so I'm just trying to irrigate, like rinse it off or whatever. So stability is pretty good, so you ask, am I over torquing this implant? No, it's not that tight. It's like, it might look like on the video, but it's not that tight. And I talked to you about this earlier, like 2 days ago too. Upper jaw, bone's usually not like D1 bone. Like I think D2 bone, even D2 bone or D1 bone is when you can have over torquing of an implant. Like you can get compression necrosis if you put the implant in too tight. So if you're getting like 100 Newton centimeters or 120 Newton centimeters on the lower jaw, and it happens when you place like these wide diameter implants, they're super strong, they're super tight basically. If it's that tight, you need to back it out, enlarge the osteotomy and replace it back. But on the upper jaw, it's very unlikely. The bone is usually like D3, like D2, borderline D3 basically, and so very less likely. And that's what, and then that's closure right there after, suturing up, healing abutment and closure there basically. And so that's what it looks like. Healing, after the healing, that's what it looks like. A very nice healing. I mean, she looks good. She's already restored. I didn't take a final photo of it, but that's what it looks like. And that's what it looks like on the x-ray there. So she's already healed up and all done basically. So